Good evening, everybody. Thank you so much for joining this webinar. It is focused on the osteoporosis. It is based as courses. This is session number 2. It is CME accredited by the Dubai Health Authority, and you're going to receive your CME certificate within 2 weeks after this CME. It is organized by the Gulf Association of Endocrinology and Diabetes within the series of scientific events organized by this society. Thank you for joining us. I'm the first speaker. I'm going to cover the clinical management of osteoporosis, non-pharmacological. I have none to disclose. And the main objective of the talk going to focus on the diagnosis of osteoporosis, prevalence of osteoporosis in the Gulf states, and non-pharmacological treatment of osteoporosis. If we look at the bone mineral density with age, it goes through a number of phases during the life, with increase in the bone mineral density during the adolescence, and the peak bone mass tend to plateau by the age of 30 to 40. After the age of 40, in a healthy person, there's a gradual decline of the bone mineral density. This decline is around 0.5 to 1% per year of the total bone mineral density. By the time a lady will get to the menopausal age, this will be accelerated as 1 to 2% of loss per year. If the age reach 80 or above, then by that time they lost almost 50% of the bone mineral density. If we look at the difference between men and women, men tend to have higher bone mineral density compared with women, and the slope of loss is slower compared with the females. If we look at the graphs here, it's very important to understand gaining a higher or bone mineral density at younger age, and there's gradual loss over time. If somebody have a low peak bone mass, then their loss will be dramatic as they proceed on at later stage of life. Somebody, for whatever reason, say taking a high dose of steroids, or having chronic illness or malnutrition, or underwent bariatric surgery, there will be sharp drop in the bone mineral density, and there is a significant loss. And these individuals may be predisposed to fractures, including fragility fractures. We tend to speak about osteoporosis less than other chronic problems or communicable diseases or non-communicable diseases. And unfortunately, when it comes to the economic impact of treatment of osteoporosis, it's very high worldwide. In USA, estimated to be almost second after cardiovascular disease. Though we don't have major talks or general educations in the health sectors, that the public and the professional as well. How would you define osteoporosis? Osteoporosis is a skeletal disorder characterized by compromised bone strength, predispose the individual to risk of fractures. And that has two components reflected by the bone density and the bone quality being affected to come up with the fragility fractures. The bone turnover is a continuous process and mostly happening in the cancellous bones, like the one in the vertebrae, and has a large surface area, and the turnover per year is very high compared with the cortical bone. And this leads to accelerated bone loss in this area, and thus predisposition to fractures in these places. Up to 10% of the adult skeleton is being remodeled at any given time And this could be increases based on certain diseases or certain medications. The bone mineral density has a normal distribution graph, and this will be shifted with age. So if you're speaking about epidemiology, prevalence or incidence of osteoporosis in society, it depends what age group you're studying. The older, the higher percentage will be there. The pathogenesis of osteoporotic fractures, it is as a result of their low bone mass, and that's related to the low bone density, post-menopausal loss, age-related, or other risk factors. This will lead to high possibility of fractures, and in this kind of population, the bone remodeling is more in favor of the osteoclast. So there is more breakdown of the bone than rebuilding the bone. It is dynamic, ongoing process of the remodeling between the osteoclast and the osteoblast, and the effect of the osteocytes. And this is being affected by a number of parameters, including the inflammatory markers, calcium, vitamin D, and protein, and other elements and hormonal part as well, namely estrogen, which has major impact on the bone remodeling. The WHO classification of post-menopausal osteoporosis is based on measurement of T-score, and if a patient has a T-score less than -2.5, it's osteoporosis, and the term used severe osteoporosis if there is fracture associated with the low T-scores. When we speak about the causes of the osteoporosis, there are many, and we should not treat a case of osteoporosis without eliminating secondary causes of osteoporosis, whether they are endocrines, nutritionals, medications, organ disorders, or other diseases. The increased intake of fizzy drinks may accelerate the bone remodeling in favor of bone loss. Medication, there are lots of medication which may induce accelerated bone loss. And when we come to the risk factor of osteoporosis and fractures, there are many. Some of them modifiable, some none. We can't do much about the age or the race, but we could do a lot about smoking, alcohol, physical activity, diet, exposure to the sun. If we look at the pattern of fragility fractures between women and men, women that tend to have more of almost linear patterns in the vertebrae and the hip with age. And when it comes to men, there's more of exponential increase at a later stage of life in the vertebrae and the hips as a fracture. And the men tend to have higher mortality rates after hip fracture compared with women. So the mortality rate is much higher in men after fragility fracture or osteoporotic fracture. The major consequences of the vertebral fractures, it's mainly the loss of independence, which is the independence in life, and the quality of life is much reduced with time. Developing kyphosis, bulging of the abdomens, recurrent dyspepsia, difficulty in breathing, and later on the activity becomes limited, and the person is either chair-bound or bed-bound. When doing the DEXA measurements, positioning the patients is very important in taking the measurement, and the proper training and certification of the technologist doing the DEXA scan is very important to get the proper results out of this. The main areas which we usually examine is the number from L1 to L4, and there are certain parameters need to be met to make sure that the readings are reliable. We look at the T-score and the Z-score. If the Z-score it is low compared with the T-score, we need to think about secondary causes. And the Z-score is quite the parameter we tend to use below the age of 40. And Z-score is match for gender and age with the reference population. The hip, we look at the neck of the femur and the impact, whether it is in the osteoporotic range, osteopenic, or normal. Now, having in the machine the trabecular bone score is very important. Most of the machine we have in the country, they could easily activate this software and be part of the reporting. This will result in much more proper evaluation of osteoporosis, because you could have two patients with the same T-score at the lumbar region, say from L1 to L4, this patient and this patient. But when you look at the architecture of the trabecular bone, they are different. And that's maybe not thought well with the T-score. But when you're doing the trabecular bone score, which looks at the homogeneity or heterogeneity of the bone structure, then you get different results here, indicating that this patient over here has weaker bone compared with his comparison. In the Gulf states, there is a consensus statement done by Dr. Yousef and his colleagues, looking at the diagnosis and management of osteoporosis and post-menopausal women in the Gulf states. And it is very good to go over this. It is a good guide in practical terms to implement it in our practice. The consensus is stated about the epidemiology of the osteoporosis in the Gulf states. Unfortunately, we don't have very accurate, robust study looking at the prevalence or incidence of osteoporosis in the Gulf states. But the figure being quoted here from small studies, around more than 20% above the age of 50 in general. And Saudi Arabia reaching 34% and 36% with osteopenia. Looking at the vitamin D deficiency, it is very wide in the Gulf states. And if we look at the osteoporosis part in terms of the diagnosis, evaluations, and management, the focus of the talk today here is the lifestyle measures. So adequate calcium intake, adequate vitamin D intake, sun exposures, daily physical activity, and prevention of falls. We should not forget that we tend to depend on the T-score only, and your computer at the hospital or the clinic. You could have the calculation tool, tracks there, and you could calculate easily as you manage the patient. It will help in the management of the patients, as it gives you a prediction, 10 years prediction of the major osteoporotic fractures or the hip fractures. And this part of the world, we have Abu Dhabi, Jordan, Palestine, Saudi Arabia, Kuwait, Tunisia, Morocco, and Lebanon. Unfortunately, this process has been shattered as a disease between rheumatologists, endocrinologists, and orthopedics. And I could see a good number of my colleagues in the orthopedic teams after a fracture, they deal with the patients, and they manage putting the patient on medication, but the majority, they tend to not look in details, look for the secondary causes of osteoporosis. Basic investigation to be done for any patient with osteoporosis are the following, looking at the renal function test, looking at if the patient has multiple myeloma or anemias or any other disorders, looking at if the patient has hyperparathyroidism, or if he has any bone disorders, or paraproteinemias or others, diabetes, and so on. More attention should be given to patients who have osteoporosis and they are men with osteoporosis, unexplained fractures, unexpected low bone mineral density, poor response to therapy, a clinical suspicion of secondary causes in a patient with osteoporosis. They need more thorough, detailed investigation to stem down what is the main cause of osteoporosis. The treatment of osteoporosis should be individualized, and it depends what is the underlying cause of osteoporosis, and it is a shared decision between the patients and the doctor. We should not rely heavily on the bone mineral density. For example, if a patient is receiving high dose of steroid for a longer time, probably the T-score and the lumbar region will not be reflective of the severity of the disease until it's too late. So we should make our own clinical decisions regarding. Smoking significantly increases the risk of fractures, especially hip fractures. And there are a number of meta-analyses looking into cigarette smoking, and it has been shown clearly it tends to increase the risk of fractures. And smoking 1 pack a day throughout life is associated with 5 to 10% reduction in bone density. Excessive alcohol consumption, excess of 2 drinks, more than 28 grams of pure alcohol per day, associated with risk of hip fractures with a relative risk of 1.39. So prevention of osteoporosis and ongoing management of osteoporosis will focus as part of it on the vitamin D supplementation, healthy diet, adequate calcium intake, and adequate protein intake, along with the regular physical activity. The physical activity is needed since early childhood to build a strong bone, a strong skeleton. And it's very important that in schools, classes of PE should not be compromised for something else. Physical activity and bringing up the new generations with keenness and exercising, involvement in sport is very important for general health. Cardiovascular risk will be reduced, diabetes and other diseases will be used, along with the bone health. It will be improved dramatically. When we speak about a patient with osteoporosis and we're advising sports or physical activity, they should advise something they could comply with, something they like, something they could engage in 30 minutes, 33 times per week at least. Whether it is aerobic, weight bearing, resistance exercising, jumping, jogging, walking. However, cycling and swimming are the least associated with increased bone mineral density. Exercise has beneficial effects in the premenopausal and postmenopausal women, and in terms of reduction of fracture risk and so on, and improvement in the mobility, agility, and prevention of falls. Calcium. When we speak about intake of calcium, it's better not to give the patients calcium a day or 3 calcium tablets a day, to reduce the number of calcium intake as tablets and increase the intake of dietary calcium from different sources as the patient they like. But focusing on dietary calcium is very important. The calcium intake tends to be of great benefit to the bone health. And there were some studies showing that high calcium intake in terms of tablets may increase the events of strokes or myocardial infarctions. This led to larger studies which revoked this potential harm if the subjects are taking adequate daily doses of calcium. Calcium tends to promote health, bone health, but however should be taken in adequate. Usually, as a physician, if a patient tells us that I drink milk, I take yogurt, I do this, it's difficult for us to estimate how much calcium intake he's taking daily from his diet. probably we need the help of a dietitian to estimate how much calcium he takes in his diet and how we could improve that based on his diet, and whether he needs calcium tablet supplements or not. The usual daily intake of calcium between 1,000 to 1,200 milligram daily. The maximum to be given is around 2,000 milligram daily. And as mentioned, better to rely on dietary products as intake. Calcium tablets, especially the calcium carbonate tablets, should be taken with meals to ensure better absorptions. And I could see in clinical practice there are a good number of patients who are taking PPI medication along with calcium carbonate tablets. If they do that, the absorption will be very poor, because calcium carbonate, they need acidic environment for better absorption. You could switch this patient to calcium citrate or calcium gluconate to ensure better absorption of calcium. Add to that when calcium is taken with a diet, then the absorption becomes there is no major peak. But if they take it an empty stomach, there is more of a peak of calcium, and that's probably not physiological in a way. In the Gulf states or in the Middle East in general, there is very high prevalence of vitamin D deficiency, as said before. Despite we are in a sunny country, we are keeping away from the sun. So the conversion in the skin to vitamin D is very little. And supplementation, whether it's D2 or D3, are highly advisable in our population. Vitamin D insufficiency or deficiency. We mentioned about sun exposures and relate to GI diseases, liver diseases, renal diseases, or taking medication like phenytoin or phenobarbital or others. Calcium and vitamin D intake is important, especially in our patients and the geriatric wards or elderly. They are deficient probably in calcium and vitamin D, and giving two together, the two supplementations, it's very important that we don't give vitamin D alone without adequate calcium, or vice versa. We give calcium and the patient is already deficient in vitamin D. How much vitamin D to give? It depends on the patient's deficiencies and his diet. A different organization recommending different doses, but overall, we keep an eye on the level of 25 hydroxy vitamin D to have it within normal range if we are following the patients. If the patient is not followed and they then advise them to take a small dose of vitamin D as a maintenance dose along with adequate diet of vitamin D. We should be careful about patients undergoing bariatric surgery with accelerated bone loss and vitamin D deficiency, pregnant ladies as well. What about active vitamin D metabolites like calcitriol or alpha calcidol? They are not advisable to be given to a patient with osteoporosis without any other reasons, because they may increase the risk of the hypercalcemia and hypercalciuria. So in summary, the non-pharmacological therapy is adequate intake of vitamin D and calcium. Calcium of 1,200 milligram daily for women above the age of 51 and men above the age of 71. No evidence of taking more than 1,200 is of benefit. Increasing dietary calcium in the first line of management is important. Vitamin D between 800 to 1,000 per day above the age of 50. Some of our patients maybe need more. Definitely patients who are deficient, they need a loading dose of vitamin D, and then it will be and maintenance the dose of vitamin D. Yet to come to cover the fall prevention, but we already spoke about the importance of exercise and avoiding smoking and excess alcohol. Falls in the elderly is common, and above the age of 65 years old, almost 30%, at least they fall once per year. 10% of the fall result in serious injuries, and 2% of the falls lead to fractures. The young population, they have the quick protective mechanism of body posture. So if they tend to put on their hands, they have a stronger body. They don't have a fracture from standing positions. And the older populations, they tend to fall on their side. The protective mechanism is weak and compromised, and they end up with hip fractures. These advice or guidance to our patients is very important to keep in mind always when we see a patient with osteoporosis. So correct visual or hearing impairment is very important. Optimizing medication, avoiding medication that cause dizziness or blurring of visions. Bathroom bars to hold on, and avoid any rugs or slippery mats. Keep electrical wires or telephone cords out of the way, and reduce clutter from the walking area. And we get a number of our patients that they wake up at night, the room is dark, and they fall down. So having a night light is very important. Handrails at the steps and stairs, walking aids, and so on. These, and even exercise that improve balance and coordination of the body, are very important. The message, along with the medication, it should be part of the management for the patients. It's very simple to say, but it be crucial. And we see lots of our patients sleeping on the floor of the toilets and bathrooms, and they fracture, unfortunately. Adequate and healthy nutrition is of great value, along with the medications. If there is a nutrition deficiency, that will lead to musculoskeletal dysfunctions, weakness in the body, leading to a reduction in the protective responses when there's a fall. Along with the person who is malnourished, they have low energy and they tend to lose their bone mass. This will lead to a fall and a fracture. If somebody is malnourished, their healing is slower, and they end up with more complications. Speaking about physical therapy, postural control is very important. Patients with, especially who have kyphosis, or the patient who have hip replacements or other, they are in need to be educated to how to coordinate their movements so to avoid falls. That's very important. So balance training, postural corrections, trunk and upper and lower extremities muscle strengthening is very important. So moderate exercise and so on, it's essential for these patients. In rodents and animal experiments, small animal experiments show that if you do a whole body vibration therapy, it will lead to a positive increase in the bone density. However, when this is subjected to humans, the benefit is less or none. I'm coming to the end of my talk. By the end, I will just put a case. You have seen a patient, AB, a 55 years old female with a menopause for the last 5 years, no symptoms currently, no history of fragility fractures, no height loss, maternal history of hip fractures, non-smoker, 1 glass of wine daily, regular exercise. She walks 3 to 4 times per week. Calcium intake is around 200 milligram daily. Past medical history, she underwent cystectomy in 1981. Now, is there indication for bone density measurement? You know the criteria for screening, above the age of 65, and the patient also. Does this patient qualify to be screened? Does she have any element or reason or risk factor make her a potential for screening? Yes. She has maternal history of hip fracture, which is strong factor here. And she's post-menopausal for 5 years, as well plays part. Now, her DEXA scan over here from L1 to L4, it shows she has osteoporotic range. It is less than minus 2.5. And when you look at the hip, the T-score is minus 2 at the neck. So, but there is a big disparity between these figures. So it's mainly, it is severe, or I would not say severe. Severe, it is she doesn't have any fractures. So she has osteoporosis at the lumbar region and osteopenia at the hip. So what's your diagnosis? Are you going to label her as post-menopausal osteoporosis? Maybe not. You need always in these patients, we need to look for secondary causes. She is young. She has disparity between the lumbar and the hip measurements. So additional history has revealed that she has flatulence occurring quite regularly for ages, intermittent slight diarrhea, diffuse bone and muscle pain. And the further laboratory investigation shows that she has a mild anemia with a hemoglobin of 11.6, her calcium on the low side, magnesium on the low, her alkaline phosphate is high, vitamin D is low, and her calcium creatinine urine levels is low. So along with the other findings, so this patient has calcium and vitamin D deficiency with secondary hyperparathyroidism. The BTH was high. Suspicion of osteomalacia, increased bone turnover, and she has iron deficiency problem. Now, what are the learning points out of this case? Always consider causes of secondary osteoporosis. Don't rely just on the T-score. Routine lab can suggest additional evaluation needed. Diagnosis of secondary cause can suggest specific treatment. This patient probably has celiac disease and she probably needs to be put on a gluten-free diet. Treatment of the underlying celiac disease alone without treatment for osteoporosis that may improve her bone mineral density dramatically. However, in patients who have GI problems, such as urinary bowel disease, Crohn's, ulcerative colitis, or others, and it is best to administer IV medication for osteoporosis if needed, or subcutaneous rather than through the GI route. Areas of potential improvement in the healthcare, risk stratification of patients, and proper follow-up. Measuring the trabecular bone score in our DEXA machines is very important. It would add value to the bone mineral density measurements and the fracts. Performing vertebral fracture assessment as part of the DEXA in all patients would be great. Performing bone turnover when needed, especially in patients who are failing treatment or they have poor response to treatment. Creating fracture liaison services in the hospital. Our patient will be lost between orthopedic rheumatologist and endocrinologist and medicine. So to have somebody capture these patients and go through the proper investigation and management will be great for the patient's care and well-being. Prevention of fractures from early stage of life and non-pharmacological treatment of osteoporosis is very important as well. When we're starting a patient with medication for osteoporosis, we should be very careful from switching from one medication to another. Labeling a patient to have failure of treatment very, very quick is of not great benefit and should be only considered when it is needed. And we go into that later on during the talks. With this, thank you so much, and the floor is open for the other speaker. Thank you.
Thank you, Professor Jumma, for your presentation. It was clear and crisp, and really like we learned a lot about non-pharmacological management of osteoporosis. Now we will move to the second part of the talk, and the second part will be given by Professor David Kindler. It's my honor actually to introduce Professor David. He is from University of British Columbia, and he's joining us now live from there. Dr. Kindler actually is a graduate of MD program in the University of Toronto, and then he practiced in New Zealand, Botswana, and Canada. After that, he joined an internal medicine program, both in Halifax and then British Columbia after that. After he finished his internal medicine and endocrinology, he went for a fellowship program in New York, and he returned back to British Columbia, and he worked as faculty and professor of medicine in the University of British Columbia. He is now professor of endocrinology, and he leads the osteoporosis program in children and women hospitals and at St. Paul hospitals. And he is a director of Pro Health Clinical Research, which is a major North American center for clinical trials in the area of osteoporosis. He served on the Scientific Advisory Council for Osteoporosis Canada and chairs of Western Osteoporosis Alliance. He is a past president of International Society for Clinical Densitometry. He is a member of the scientific committee for International Osteoporosis Foundation, and he is a recipient of the John Balzikian ISCD Global Leadership Award. He has served on the board of directors of the Canadian Menopause Society, and he has published over 140 peer-reviewed papers on osteoporosis and therapeutics, osteoporosis risk assessment, and autoimmune thyroid disease. For the participant, please write all your questions and answers, and at the end we will try to answer as much as we can. There is 20 minutes allocated for that. So Professor David, go ahead and deliver your talk, and the title of the talk is Anabolic Treatment for Osteoporosis. Please go ahead.
So it's my pleasure to present to you a summary of bone anabolic therapies for osteoporosis, an area of great interest these days, with the availability of new therapies and new guidelines helping us to orient which patients are going to be good candidates for anabolic therapies. So these are my disclosures. I've had funding from a variety of pharma, doing research studies, as well as lectures and consultancies. So what I'd like to cover first are some of the care gaps in osteoporosis management, and that leading into which patients would be good candidates for bone anabolic therapy, those being patients at very high or imminent fracture risk. And then I'll deal with the bone anabolic therapies that we have available. Teriparatide, you well know that from a long time ago. I'll talk briefly about that. Abaloparatide is a PTHRP analog available in the US, but not other countries as yet. And I'll focus on Rhomazosima, an anti-sclerostin antibody, which has just been approved in the US and Canada and many countries. And finally, I'll briefly talk about osteoporosis treatment guidelines. So let's start with a case. Here's a 7-year-old female presenting with a proximal humerus fracture, and she's found to have incidental spine fractures. And you can see a number of vertebral fractures in her spine radiograph. And so this patient clearly has severe osteoporosis. What treatment should we offer this patient? Should we start with an anti-resorber and then move to an anabolic? Or should we start with an anabolic and then move to an anti-resorber? Should we just say, well, denosumab is a pretty good anti-resorptive therapy, and that should be good enough just on its own? Well, denosumab is a very good anti-resorptive therapy, and certainly for vertebral fractures, we see that in the first year here in the FREEDOM study, patients on denosumab in purple as compared to those on placebo in gray, in the first year there was a 61% reduction in clinical vertebral fractures, and at the end of the third year, almost a 70% reduction in vertebral fractures. So pretty effective in reducing vertebral fractures. However, for non-vertebral fractures, the results are somewhat different. You can see between placebo and denosumab, the curves only begin to separate after the 12 or 18-month time point, and at the end of 3 years in the FREEDOM study, there was only a 20% reduction in non-vertebral fractures. So much lesser efficacy in terms of non-vertebral fractures as compared to vertebral fractures. And so there are some unmet needs by anti-resorbers for patients who are at very high risk of fracture. The magnitude of effect, I've shown you the non-vertebral fracture risk reduction around 20 or 30% as compared to vertebral fracture risk reductions of 70%. The time to efficacy, the significant non-vertebral fracture efficacy is only evident after 2 or 3 years. And of course, we need to focus on getting patients to adhere to therapy. And the 2-year persistence to oral bisphosphonates in a recent meta-analysis, 70% of publications showed less than 30% of patients still on therapy after 2 years. So how do we define this very high-risk patient? Well, we could look at clinical risk factors, and these are data from Sweden looking at actual 10-year fracture data. And so on the vertical axis is 10-year fracture risk. On the horizontal axis is BMD T-scores. And you can see in the red, patients without any clinical risk factors do have increasing 10-year fracture risk as they go to lower and lower T-scores. But if you add in prior fracture, as with our patient, you can see that there's a jump up in terms of 10-year fracture risk. If you add as well glucocorticoids, it jumps up further. And with the addition of family history, you can get 10-year fracture risks of greater than 70% if patients have a BMD T-score of -3 or less. And so multiple risk factors clearly can contribute to a very high fracture risk patient. Imminent fracture risk is another concept that you should be aware of, and these are data from a US Medicare database of almost 400,000 female patients in the US over the age of 65 who had an initial osteoporotic fracture, and then they were followed for a subsequent osteoporotic fracture. And this analysis included all fractures except for face, skull, fingers, and toes. And you can see after 1 year, 10% of patients after an initial fracture had a subsequent fracture. This is very high risk. And after 5 years from their initial index fracture, 30% of them have had a subsequent clinical fracture. So this defines a patient population who are at very high risk. Now, if we look at the normal bone remodeling unit, we can see that osteoclasts will carve out a bone resorption space, and they do that over the course of about 3 weeks. And then over the next 2 to 3 months, the osteoblasts move in and ideally fill that up to the same level it was before the osteoclasts carved out the resorption space. In postmenopausal osteoporosis, there's an excess of osteoclasts and they dig pits which are excessively deep, and the osteoblasts cannot keep up. And so those resorption pits are incompletely refilled, leading to, for every bone remodeling unit, a net loss of bone. And of course, the anti-resorbers, bisphosphonates, SERMs, estrogen, and denosumab will reduce the activity of osteoclasts and restore a balance. And so they can be very effective therapies for postmenopausal osteoporosis. The PTH agonists, for instance, teriparatide or abaloparatide that we'll present briefly, are agents which stimulate the osteoblast more so than the osteoclasts. So osteoclasts are stimulated to resorb more bone, but to a greater degree, the osteoblast is stimulated to form new bone within the resorption space. And there is some modeling, that is new bone formation on quiescent bone surfaces as a spillover effect, but about 90% of the new bone formed is within that resorption space. The sclerostin monoclonal antibodies act differently, and so they are also anabolics, but their action is to suppress the activity of the osteoclast and to stimulate osteoblastic bone formation, mostly on quiescent bone surfaces. And so that's modeling-based bone formation. And about 90% of the new bone formed under the influence of a sclerostin monoclonal antibody is on a quiescent bone surface, and only about 10% within the resorption space. So a relevant question is, are bone anabolic therapies superior to anti-resorptive therapies? And before 3 years ago, we really didn't have the answer to that question. We had bone turnover marker studies and bone density studies, but what we really want are head-to-head fracture endpoint studies. And the first study to be published was our Vero study, which looked at about 1,400 postmenopausal women aged 45 or older, with at least 2 moderate or 1 severe vertebral fracture, and BMD T-scores of less than or equal to minus 1.5 at one of the relevant sites. And they were randomized to daily teriparatide or weekly risedronate. And you can see that over the first year of the study, patients on teriparatide in blue as compared to risedronate in red had a 50% reduction in the risk of new vertebral fractures. That continued, and there was about a 36% reduction in new vertebral fractures in the second year. And at the 24-month time point, there was a 61% reduction in the risk of new vertebral fractures, or primary endpoint in that study. And this addressed the issue of the additional value that we see with bone anabolic therapy. And I draw your attention to the fact that over 2 years, 11% of patients on risedronate, which is an effective anti-resorber, maybe reducing vertebral fractures by 40 or 50%, 11% of patients would have a new vertebral fracture occurring over that 2-year time point. So that's a very high burden of illness, residual burden of illness in patients given just anti-resorbers if they've got very high fracture risk. And we saw clinical fractures also reduced by 52% in patients on teriparatide as compared to risedronate. And you can see that the curves begin to separate at around the 6-month time point and continue to separate out to the end of the 2-year study. Only one slide on abaloparatide. This is a PDHRP analog, which is available in the US only at present, but applications being made elsewhere. And that agent was trialed in a study called the ACTIVE study in postmenopausal women. And it looked at patients on placebo in blue, on abaloparatide in red, and there was an open label arm with teriparatide in green. And what they showed is that both abaloparatide and teriparatide showed significant reductions in the risk of vertebral fractures. There were also reductions in non-vertebral fractures and clinical fractures. The study was not powered to look at comparing abaloparatide with teriparatide, but both agents were effective as compared to placebo. So sclerostin is an agent which is produced by osteocytes and osteoblasts, and it is a controller of the bone anabolic pathway, and that's called the Wnt signaling pathway. So how does that work? There is a protein called Wnt, which binds to a transmembrane protein, LRP56, and a transmembrane receptor called frizzled. And if it binds, then it activates that receptor and transduces signal down to the nucleus and activates the osteoblast to form new bone. So this is the Wnt signaling pathway turned on with Wnt binding its receptor. If sclerostin is present, these little brown wiggly lines, then it binds to LRP456 and it prevents the binding of Wnt. It prevents the activation of the frizzled transmembrane receptor. And so Wnt signaling is turned off. And so it stops bone formation. So the sclerostin antibodies take away sclerostin, and they direct that the Wnt pathway, the bone anabolic pathway, can be active. And so they stimulate bone formation very dramatically. So romosozumab is the first clinically indicated sclerostin antibody. It is a humanized monoclonal antibody. It is, of course, effective or appropriate for use in patients at very high risk of fracture or imminent risk of fracture, given its rapid onset of action. It may be given in patients with previous vertebral multiple fractures or recent fragility fractures, such as in our patient presented, or with multiple risk factors. It does have the potential for a cardiovascular signal, and I'll show you more data on that in a moment. So the label restriction is that there should be no myocardial infarction or stroke in the past year. And the dosing is 210 milligrams every 4 weeks. Each monthly dose is given as 2 injections of 105 milligrams each. That's because the volume of injection is too large for a single injection. And the therapy is monthly for 12 months, and after completion, transition to an anti-resorptive therapy is required in order to maintain the anabolic benefit. So prior to initiating romosozumab treatment, it's important to evaluate the patient, look at their serum calcium, make sure that if they are hypocalcemic, you evaluate that and correct it. They also need to be on adequate calcium and vitamin D. This because romosozumab is an agent which is going to lead to the uptake of a lot of calcium into the skeleton. And in addition to its anabolic action, it has anti-resorptive actions, both of which may contribute to hypocalcemia if there's inadequate intake of calcium and vitamin D. If one's going to monitor, one could use biomarkers. If you're going to do that, the time to measure P1NP is 1 or 2 months after the first injection of romosozumab. You can see P1NP as a marker of osteoblast function goes up about 150% in the first month. And then with subsequent injections of romosozumab, you can see that the effect on that osteoblast marker attenuates and becomes less. C-telopeptide is suppressed by about 50%, and that effect is maintained as one goes out to the end of the 12 months of therapy. And so romosozumab has a dual action, partially as a very potent anabolic stimulating the osteoblast, and in part as an anti-resorber inhibiting the osteoclast. Now, it's important that there be, after the year on romosozumab, an anti-resorptive therapy to continue on with, because as you can see here in this phase 2 study where patients were given 2 years of romosozumab, nice increases of spine and hip bone density, and then crossed over to calcium and vitamin D, all of that benefit, all of that increase in bone density being lost over the subsequent year. And so transition to an anti-resorber is essential. So sequential therapy, romosozumab is just for 1 year, and we do have data on anti-resorptive therapies subsequently, including alendronate, zoledronic acid, and denosumab. And clinically, of course, we may use romosozumab after anti-resorptive therapy with alendronate or denosumab in cases of treatment failure or inadequate efficacy. But the optimal sequencing involves the anabolic first, as you get lesser improvements in bone density if you give the anabolic after an anti-resorber as compared to the reverse sequence. So the 2 trials for romosozumab, the first called the FRAME study, and that was a very large study of about 7,200 postmenopausal women with osteoporosis. They had to have a T-score between -2.5 and -3.5, but they were not particularly at high risk of fracture. And they were given romosozumab or placebo in a double-blind fashion for 12 months, following which they had open-label denosumab, which they carried on with for a further 2 years. So the co-primary endpoints were the incidence of new vertebral fractures at 12 and 24 months. And you can see a low risk of vertebral fractures in patients on placebo as compared to Rhomazosima, but a 73% reduction in the incidence of new vertebral fractures at 12 months and a 75% reduction at the end of 24 months, that being 1 year on Rhomazosima and then followed by a year on denosumab. There was also a significant 36% reduction in clinical fractures in the Rhomazosima group as compared to the placebo group. The ARCH study was a head-to-head study of Rhomazosima versus alendronate in patients who were at high risk of fracture. And these patients had to have not just a low bone density, but they had to have 1 or more moderate or severe vertebral fractures or 2 or more mild vertebral fractures in addition to low bone density. And so this higher risk population could not be trialed with placebo, but they were rather randomized to either a year of Rhomazosima or a year of alendronate. And then subsequently, every patient was switched over to alendronate and followed on up to about 3 years. And so this study demonstrated, again, a high residual burden of illness, about a 12% incidence of new vertebral fractures in patients who were given alendronate for 2 years, as compared to 6.2% in patients on Rhomazosima, that representing a 48% reduction in the incidence of new vertebral fractures. And you can see on this Kaplan-Meier curve that for clinical fractures, the curves again begin to separate early at about the 12 to 18 month time point, and clinical fractures being reduced by about 27% as compared to alendronate therapy at the end of 48 months. The Bmd effects of Rhomazosima, much greater than alendronate, about a 14% increase in spine bone density, about a 6% increase in total hip bone density, with much less increases in bone density in spine and hip on alendronate. So the other question to answer is, how do you compare Rhomazosima with teriparatide? They're both good anabolic therapies. And there was a study, the Structure study, which looked at patients who were long-term on bisphosphonate, an average of 6 years prior to being randomized to either teriparatide in the yellow or Rhomazosima in the blue for 1 year of therapy. And here you can see the primary endpoint, total hip bone density, which went up by about 3% in patients on Rhomazosima over a year. And as we know, patients switching from bisphosphonate to teriparatide do not have much of a positive effect on hip bone density, and there was significant lesser effect than with Rhomazosima. And that could be translated into hip strength by finite element analysis from CT of the proximal femur, where we saw increases in hip strength on Rhomazosima over the year with no change in patients on teriparatide. So what about safety? That's very important to our patients. And I mentioned that patients who have cardiovascular risk are probably not good candidates for Rhomazosima. And that's because there was a signal in one of the 2 studies which I presented to you of myocardial infarction and stroke. And so the contraindication from the FDA label is that patients who have had a myocardial infarction or stroke within the past year are not good candidates for Rhomazosima, and you should be careful in patients who have high risk of myocardial infarction or stroke. And I'll show you the data where this came from. If we look at the FRAME study, remember that's Rhomazosima versus placebo. You're looking at placebo in the light blue and Romo in the dark blue. And over the first year, there is absolutely no difference in MACE events. Those are cardiovascular events. And then as patients are transitioned over to denosumab, again, the curves are superimposable. So there's no cardiovascular risk either in the placebo control time or in the subsequent time when patients were on denosumab. In the ARCH study, however, the accumulation of MACE events was greater in patients on Rhomazosima in the first year as compared to alendronate. This primarily because of 2 times in the first 3 months of the study and between the 9th and the 12th month in the study, when in the alendronate arms, there were very few MACE events. And then as one continued all patients on alendronate, the curves gradually moved together such that at the end of 36 months, there was no significant difference in MACE events. And so the explanation of this is unclear, but it may be a chance occurrence that the alendronate arm just happened to not have many MACE events. We don't think alendronate prevents cardiovascular events. But we don't have an explanation. And if you look at the shape of the curve and how it doesn't really change as one goes from rhomazosima to alendronate, there's a steady accumulation of cardiovascular events. It likely is that that's a chance finding. So finally, in terms of guidelines, we now have the American Association of Clinical Endocrinologists 2020 guidelines, which are highlighting a role for bone anabolic therapy. And so they would say if your patient is at high risk with no prior fracture, then one of the anti-resorbers would be appropriate. But if a patient is very high risk, prior fractures, the anabolics of abaloparatide, romosozumab, and teriparatide, or the parenteral anti-resorbers, denosumab and zoledronic acid, would play a primary role and should be perhaps a first choice for those patients at very high risk. And they defined very high risk as patients with a recent fracture, such as the case we presented, a fracture while on approved osteoporosis therapy, multiple fractures, fractures while on drugs causing harm to the skeleton, like corticoids, a very low T-score, they suggested less than a T-score of -3, a very high risk of falls or injurious falls, or a very high fracture probability by FRAX. And they suggested a major osteoporotic fracture risk of greater than 30% or hip fracture risk of greater than 4.5% might define a patient in this very high risk category. So back to our patient, recall she presented with a proximal humerus fracture and incidental note of spine fractures, clearly at very high risk. And I think you would make a good argument for this patient who is both at very high fracture risk and at imminent fracture risk, that she should be best sequenced with anabolic therapy first, followed by an anti-resorber. So in summary, bone anabolic therapies will benefit osteoporosis patients at very high risk. And the anabolic therapies stimulating the PTH receptor, the remodeling-based anabolics, create new bone within the resorption space. Sclerostin antibody therapy creates new bone on quiescent bone surfaces. And I've introduced you to the Wnt signaling pathway, which involves sclerostin as an osteoblast inhibitor. And so the inhibition of sclerostin is a mechanism to give anabolic effect to bone and reduce fracture risk. And finally, anabolic therapy should be seen as first line in patients at very high risk of fracture. And you can see the updated guidelines, for example, the AACE guidelines help to direct us for the appropriate use of bone anabolic therapy.
Thank you, David, for your presentation. It's really, we enjoyed it and we learned a lot from it. We will go to the third speaker, and we're lucky this evening to have Dr. Yousef Alsaleh. He's well known to us in the region, and he's one of the physicians who's focusing his practice and research on osteoporosis. Dr. Yousef Alsaleh is from Saudi Arabia. He's Associate Professor of Medicine and Endocrinology at King Saud bin Abdulaziz University for Health Sciences. He's also a consultant endocrinologist at Division of Endocrinology, Department of Medicine, King Abdulaziz Medical City in Riyadh, Kingdom, Saudi Arabia. Dr. Yousef has obtained his MRCP London in 1984. He also obtained the Arab Board in Internal Medicine in 1996. He did a fellowship in endocrinology and diabetes at the University of California, San Diego in 1998. He has a diploma in healthcare and hospital management from American University at Cairo. He's associate professor at King Saud bin Abdulaziz University till now, and he's also looking after the teaching program there, and also he's the president and scientific council of medicine and all residency training program across the United Kingdom. Dr. Yousef will focus his talk about clinical management, and his talk will be focusing on anti-resorptive. The floor is yours, Dr. Yousef, and welcome. Please go ahead.
Thank you very much, Abdullah. Assalamu alaikum jami'an. Good evening, everybody. Maybe good morning to David, whom I greet. Currently, he's in Canada. So my talk is about anti-resorptives. I do thank the webinar committee of the Gulf Association of Endocrinology and Diabetes to give me the chance to speak. And thank you, Abdullah, for the kind introduction. These are my disclosures. And this is the outline of my presentation. Just a few slides about the consequences of osteoporosis, a rapid review of anti-resorptives that we have in our hands to treat our patients with osteoporosis, a comparison between bisphosphonates and denosumab, and conclusion. We know that osteoporotic fractures are common and probably not in this part of the world compared to the rest of the world based on statistics that we have, but we still have a lot of these patients coming with vertebral, multiple vertebral and hip fractures. And once they fracture, they continue to fracture. So this is the risk of somebody who fractured a wrist to have the other wrist fracture if not treated more than 3 times. But the main issue or challenge is patients with hip fractures, whom if you don't treat will continue to have 2 times risk of fracturing the other hip and 2.5 times to fracture a vertebral body. Those vertebral collapses that we see on x-rays and in many instances are ignored by healthcare practitioners make that person, if he has 1 vertebral collapse, 4 times to have more and more vertebrae affected, and at the end up with kyphosis. But also that person is 2 times, more than 2 times, to have hip fracture. So patients with osteoporosis, once they start fracturing, they continue to do that unless somebody interferes in treatment. This is looking at the incidence of new fractures once a patient have a fracture, and the risk comes higher and higher, especially in the first 2 years. And this is what we call imminent risk, but it plateaus but continues to be much higher than the baseline. So saying the same, what I've mentioned in the previous talk, that in the previous slide, that patients with osteoporotic fractures continue to fracture unless you interfere and treat them properly. We're lucky in this part of the world that we have guidelines for osteoporosis. This is our 2015 guidelines in the kingdom, and our colleagues in Kuwait have also their guidelines, which is FRAX based. And also I must say that we have GCC consensus report on osteoporosis, which I did not show on this slide, but it's available and published, and you can look at them to have an overview on the approach to patients with osteoporosis. Now, once you diagnose a patient, and my task is to talk about treatment here, not to how to start therapy and who is the eligible person for therapy. But once you decided that this patient or this person needs treatment, you need to counsel on osteoporosis and fracture. Our colleague Jumma Alkaabi talked very nicely about the approach to prevention and the counseling and the important lifestyle aspects that we need to tell our patients about, including the fall prevention strategies. Advices on vitamin D and calcium intake, advice on increased outdoor physical activity. Now, talking about vitamin D, which is very prevalent here, this is what we've mentioned in the Saudi osteoporosis guidelines in 2015, that probably best to reach a 30 nanogram per ml, 75 nanomole in patients with osteoporosis. Supplement with vitamin D3 if needed, 1,000 to 2,000 international units or equivalent of daily maintenance therapy needed to maintain optimal serum 25D. Higher doses may be necessary in patients with obesity, malabsorption, transplant, and certain ethnicity, and older individuals. So always try to keep vitamin D level in your patient with osteoporosis close to 75 nanomole. We have this vitamin D consensus consensus report in association with ISQ, and this is published in 2017. This is for the Kingdom of Saudi Arabia, but also we have a GCC expert consensus summary on the diagnosis and management of vitamin D in the Gulf states. And this work was nicely done by wonderful colleagues. Some of them are with us in this webinar. What are the pharmacological agents that we have for the therapy of osteoporosis? We have the inhibitors of bone turnover, and these are the anti-resorptives, which I'm going to focus in the coming minutes on them. Hormone replacement, we have the old and still ongoing bisphosphonates, the SERMs and denosumab or Prolia. Stimulator of bone formation have been covered by our colleague David. This is the FED trial, which is a well-known trial of alendronate, comparing alendronate to placebo. And this is in Lancet in 1996. The nice comparison is there, looking at fracture rate with our hip, clinical vertebral and wrist fractures in patient on alendronate compared to placebo. And the comparison is very clear, with excellent result with this agent, which is given, as you know, once a week. This is another study of zoledronic acid compared to placebo, looking at clinical non-vertebral and hip fractures, placebo in blue and zoledronic acid in red. And you can see the nice reduction overall, 35% reduction of fracture rate, and not also reduction in fractures, but also 28% reduction in relative risk of death with once a year zoledronic acid if given in the immediate post-hip fracture period. So this is again showing the reduction in mortality with zoledronic acid compared to placebo, and the separation starts almost a year and 16 months after the infusion of zoledronic acid to patients in the hospital post-fracture. We have safety issues. Of course, we have other bisphosphonates, including risodronate and ibandronate, but the most commonly used agent in the Gulf is alendronate or Fosamax and zoledronic acid once a year. The safety issues with them, as you know, the oversuppression of bone remodeling, which was being a concern, and some biopsy studies showed the inhibition of the repair of microcracks in the bone, and that can accumulate and lead to stress fractures, and in the extreme cases, mid-shaft femoral fractures. Renal safety, and that for what reason that we don't advise giving alendronate or zoledronic acid in patients with GFR below 30. Some people say 40. And be careful with hydration status. There have been reports of acute renal injury with zoledronic acid if given once a year in patients who are dehydrated. So you need to hydrate them well and then give the infusion. Mid-shaft femoral fractures, long bone fractures, very scary looking fractures, and which in the mid-shaft of long bones. This is an example of one of our patients who developed this after 8 years of continuous alendronate use. Other side effects, as you know, of these agents, upper GI, musculoskeletal pain. The first phase reaction, it can be very severe with zoledronic acid, so alarm the patient and give them some treatment to treat that once they develop it. Back to this sort of long bone fractures with bisphosphonates. I'm missing some slides, but anyway. The risk is very small, and always when patient comes with that, x-ray the other limb to look for a horizontal line. If they have that line on the other limb, then the patient should be referred to our colleagues in orthopedic surgery for nailing of that long bone. Otherwise, it will follow the broken bone and get broken as well. The effect of hormone replacement. So we'll go from bisphosphonates to hormone replacement. This is the clinical outcome of the Women's Health Initiative with estrogen and progesterone combination. And estrogen hormone replacement nicely decrease hip fracture 34%, vertebral fracture 34%, and 23% other fractures. So very effective, but the side effects are huge, and the balance of the risk-benefit ratio is towards more risk with DVTs and PE and breast cancer, and for which we do not advocate the use of hormone replacement as treatment for osteoporosis. One slide about selective estrogen receptor modulators as an anti-resorptive. They reduce vertebral fractures, and this is with Evista, 30% reduction in the risk of vertebral fractures, but has no effect on non-vertebral fractures compared to placebo. I wonder if anybody is using them. I personally, for not using them at all, and they are fading away from practice because of their weak effect. No effect on non-vertebral fractures collectively, and of course that includes hip fractures. Some people say that raloxifene and ibandronate, which is another bisphosphonate which can be given once a month, may be appropriate initial therapy in some cases where patients requiring drugs with spine-specific efficacy, which is rare because, as we've mentioned, patients with vertebral fractures have also a risk of getting hip fractures. Shifting gear to denosumab, and we know denosumab acts by inhibiting the linkage between rank and with on its ligand on pre-fusion osteoclast, and that will prevent the maturation of osteoclast to activated osteoclasts which eats bone. So basically it acts by inhibiting the action of osteoclast, and this is the reason why we consider denosumab as anti-resorptive. This is the effect of denosumab over 6 years compared to placebo in the first 3 years, and this is the effect on bone mineral density at the hip. Very significant, beautiful increment in hip densitometry over 6 years of continuous therapy. Placebo patients, 3 years, this is their curve, and once they are given denosumab, they pick up their density and they gain densitometry in great rate. So very effective in reducing and improving bone densitometry, and this is the effect, the 3 years data on vertebral, non-vertebral, and hip fractures, placebo in blue and denosumab in red, and all of them significant reduction of all of these types of fractures with the use of denosumab over 3 years. Taking these data to 4 to 6 years and comparing to placebo to Prolia, years 1 to 3 and then 4 to 6. This is the overall population of the freedom, and then the extension to 6 years, continuous reduction in the incidence of the most feared fractures, which are hip fractures. And in higher risk patients above 75, which I'm going also to focus in 1 or 2 slides, coming 1 or 2 slides, 75 years in the extension, again, long-term Prolia use up to 6 years, maintain the efficacy of reducing hip fracture rates. This is a summary of all the evidence of fracture risk reduction with all anti-resorptives that we have. So alendronate, reduction in vertebral, non-vertebral, and hip. Calcitonin is no longer used, but anyway, it used to be effective at the vertebral column only. Denosumab reduces all of them. Ibandronate, vertebral, no effect demonstrated for the non-vertebral and the hip. If you look at raloxifene, vertebral fractures only, residronate, all of them, vertebral, non-vertebral, and hip. And zoledronic acid reduction in all of these fractures as well. So it seems that all of the agents reduce vertebral fractures. The differences are on the effect on non-vertebral and hip. This is a slide showing the patient with compliance with bisphosphonate, and there is a concern about the compliance issue. As we know, we thought that giving our patients Fosamax for once a week is going to be the compliance will be achieved, and in fact studies have shown that probably that's not true, but in patients who have more than 80% compliance, you get the benefit of oral bisphosphonates. Patients above 80 years of age, if they are having 80% compliance, and those also 60 to 80, they have 2.5 times rate of reduction of fractures if they get compliance with therapy, especially if they have correction for vitamin D deficiency and if they have recent fracture. So elderly people with recent fracture corrected vitamin D deficiency, they benefit from proper compliance with using bisphosphonate treatment. So this is a post-hoc analysis talking about the effect of age, and we always query if our agents are working in patients who are elderly. This is zoledronic acid and fracture risk in patients 75 years of age, shown here at the end of the slide, and this showed significant effect of 20% only. So the p-value was not significant, but they tend to have a tendency to have reduction in hip fractures if above 75 years of old. If you include the 75 years of age patients with the overall group, the overall rate of reduction is clinically or statistically significant. So we'll continue to use our agents, whether bisphosphonates or denosumab, in elder population, although we don't have studies specific for this population. Again, this is denosumab. So the previous study is using zoledronic acid in above 75 years of age, and this denosumab showed clearly also reduction in the risk, comparing 75, less than 75 with those above 75, significant reduction of the rate of fractures with the use of hip fractures of the use of denosumab in the elderly population. So overall fact, or what I can say at this point, that elderly population benefit from our therapy for osteoporosis, whether bisphosphonate or denosumab. This is a slide showing the change from baseline comparing these two therapies. So I was talking about the efficacy in elderly between zoledronic acid and DMAB, but if you look at the BMD changes, denosumab has significantly more gain in BMD compared to zoledronic acid. This is in lumbar spine, total hip, femoral neck, and 1/3 radius. So overall, BMD improvement is better with the denosumab compared to bisphosphonate, which is in this case zoledronic acid. Slide is not moving. And also the effect of this agent is there. This is comparing denosumab comparing to alendronate. And this is not to head-to-head comparison, except from some of these agents. Denosumab compared to ibandronate, DMAB compared to risodronate, and zoledronic acid here. And all of them showed that 1 year BMD gain at hip with denosumab is better than bisphosphonate in patients who are pre-treated with these agents. So BMD benefit of DMAB is better than bisphosphonate, and this is one comparison that I wanted to make. A question of anti-resorptive therapy: for how long do we treat? 5 years with oral therapy, although the data did not support regulatory restriction on the duration of drug use. So there is nothing written in the FDA approval that you need to use alendronate and equivalent for 5 years. Now you have to take your decision on the need to treat based on your clinical judgment, because some patients need to be carried to therapy with up to 10 years and above, but note in mind that according to the FLIX trial of alendronate, the only kind of fractures that need you get benefit if you use alendronate above 5 years is clinical vertebral fractures. So patients who are coming to the emergency room with back pain and you find back vertebral collapse. So this is the only type of patients who benefit from the use of alendronate beyond 5 years. And this is a limitation for the use of bisphosphonate in patients with osteoporosis. So this is 5 years, beyond 5 years with alendronate. What happens to the BMD changes? If you stop shift placebo patients, stop alendronate, there is a drop in the rate of BMD gain. And if you look at zoledronic acid stopping of treatment, again you find this drop in the rate of the BMD that you gained in the beginning of therapy. So this is zoledronic acid shifted to placebo. While you continue to maintain your bone mineral density. So the BMD changes are maintained 5 to 10 years after starting therapy. This is a head-to-head comparison, DMAB compared to placebo, and then extended. So this is the extension trial actually of denosumab, which is an open label, and this is the 10 years data of denosumab 60 milligram, and patients with placebo shifted to DMAB up to 7 years. What happened to patients who are continued on denosumab for 10 years? Continuous gain of BMD. This is placebo patient shifted to denosumab, 16.5% gain in lumbar spine BMD, and 21.7 gain in BMD lumbar spine with denosumab over 10 years. So significant gain in density with continuation of therapy. So the effect of denosumab on total hip BMD and non-vertebral fracture through 10 years. So this is total hip comparable to the gain in spine densitometry, 9.2% gain in densitometry of the hip over 10 years of the use of denosumab. What happened to the extension trial and the rate of non-vertebral fractures? Again, the rate of non-vertebral fractures continue. So this is the year of denosumab treatment, and you can see the gain in BMD and the incidence of non-vertebral fractures compared to placebo in white, the continuous reduction in these fractures. Adverse events with denosumab, if you look at serious and infections and malignancies, whether in the crossover patients from placebo or long-term denosumab, were comparable with no increment in any serious adverse events and malignancies. So it's quite a safe agent, and for those of you who are using the agent, this is all adverse effect in the freedom trial 1 to 3 years and the extension 1 to 7 years. You have to be careful with hypocalcemia. So treat your patient with vitamin D and calcium before giving a dose of denosumab. Otherwise, you might get some reduction in serum calcium with this agent. Osteonecrosis of the jaw, there is no difference actually compared to placebo. You might get more cases of cellulitis at the injection sites, and again hypocalcemia, rare cases of pancreatitis, similar between placebo and denosumab. So overall, very safe agents. One thing about the relationship between total hip T-score and non-vertebral fracture, the more and more reduction in the T-score of the hip will increase the rate of non-vertebral fractures. So just to recap what I've said in this presentation, that anti-resorptive are effective agents, and their efficacy, especially with DMAB, is extending up to 10 years. One notice, once you stop denosumab, you get more rate of vertebral fractures. So always shift the patient to another anti-resorptive if you have to stop denosumab. We are not sure about the duration of therapy, but at least from the data that we have, it's effective up to 10 years after starting it. And so far, no significant reports about major side effects from continuation of therapy. The bisphosphonates are still very effective, and these agents can be used again in high-risk patients beyond 5 years. The only type of fracture that you get reduction with them if you use them beyond 5 years are clinical vertebral fractures. We are not sure if there is reduction with hip fractures with bisphosphonates beyond 5 years, but most experts think that they are still effective. So this is the end of my talk. Identify and treat patients at high risk, especially for hip fractures, which are the most feared one, and other fragility fractures, and switch to the most efficient drug. Probably denosumab at this stage is the best anti-resorptive that we have in our hand, and long-term, more than 5 years therapy is necessary in patients remaining at high risk. And comparing denosumab to bisphosphonates, if you have to use long-term therapy, probably denosumab is a better agent with the evidence that we have up to this date. Thank you.
Thank you, Dr. Yousef, for this presentation. It was clear, and also we learned a lot from it. thank you for staying with us and be patient with us. And as you know, this is a second session. There will be a third session on the 30th of this month. And please join us then. And we are having also the main conference of the Gulf Association. You will receive more information about that, and the organizer has put together a nice program for you. We have reached actually the last session, and before that, don't forget your question and answers. The panels will meet again and try to clarify any points which was not clear to you in the presentation. So again, we come to the end where Professor David Kindler will give us practical clinical cases, which help us to apply the knowledge we have learned today. So please go ahead.
So it's my pleasure now to present two case studies in osteoporosis to highlight some of the more recent advances and ideas that we have in treating our osteoporosis patients. Again, these are my disclosures. So case one is an 82-year-old female who suffered a left femoral neck fracture after a fall from standing height. Previously, she was independently living. She did have a history of a prior fracture, but many years ago at age 70. And at that point, she had a femoral neck bone density T-score of -2.8 and was initiated on alendronate. And she took that for 5 years, from age 70 to age 75. And then, like many of our patients, discontinued therapy because she felt she had been on it long enough. And her concern was atypical femoral fractures. And so for the past 7 years, she was on drug holiday. That was the 7 years prior to her hip fracture. So we know that hip fractures are devastating. We know they're common. About 1 in 6 post-menopausal women in North America will have a hip fracture in their remaining life. And hip fractures are a major cause of disability and premature death. A third of patients after hip fracture remain institutionalized for at least a year and have to return home, but must depend on other people for their mobility. And even in North America, there's a 20 to 25% mortality in the first year after hip fracture. And we know that hip fractures commonly in the femoral neck or intertrochanteric area, but it's important to note that 10% of hip fractures are subtrochanteric. And I raise this because when we talk about atypical femoral fractures, some of the radiologists and orthopedic surgeons would consider anything in the subtrochanteric location to be an AFF, and that's not so. These are common fractures, not as common as intertrochanteric or femoral neck, but they are common fractures occurring in patients unrelated to or unassociated with any osteoporosis treatment. So this patient was on drug holiday. Is that a good or a bad thing? And of course, there are some benefits. Holiday sounds nice. There are cost savings to not being on a medication. And the reason most people wish to limit their duration of therapy with osteoporosis treatments is because of rare side effects, atypical femoral fractures and ONJ. And we do have data suggesting that these may be reduced if treatment is interrupted. But there are risks. We know that the resolution of bisphosphonate effects occurs more gradually than most medications. However, there are certainly declining BMDs, and eventually we see fractures occurring in patients who go on drug holidays. So there are benefits and risks, and we must present the balance between risks and benefits fairly to our patients. And we know that if patients are left to their own devices, that they will choose drug holiday. These are some Medicare and Medicaid data recently published by Jeff Curtis, showing that from 2010 through to 2014, there has been a dramatic rise in the number of patients on bisphosphonates who choose to take a drug holiday, and approximately 6% per year in 2014 went on drug holiday. So the ASBMR has weighed in on this with a task force, and the task force determined that if you
have ongoing risks. That is, if you've had a hip or a spine or multiple osteoporotic fractures, then drug holiday is not a good idea for you. However, if you have a bone density T-score at the hip of better than -2.5, and you don't have high fracture risk, as they defined it, then you could consider a drug holiday. But important, they did say reassess every 2 to 3 years. And very often patients who go on drug holiday look on this as a retirement rather than a holiday, and they stop treatment for longer periods of time, or in the case of our patient, until a fracture should occur. So let's imagine that one day before our patient's hip fracture, we had an opportunity to evaluate her. And we measured her bone density, and let's say it was -2.4. You recall she started at -2.8, and that would be a usual increase in bone density in patients on alendronate, and perhaps some declines on drug holiday. And if we used here the Kuwait fracs, we could calculate what her risk of major osteoporotic fracture, 11%, and hip fracture, 4%. So we might, if we did take an opportunity to reevaluate this patient, determine her to be at high risk for fracture, and we might have decided that a treatment would again be indicated. Now we await a Saudi calibration for FRAX, and in the meantime, we're left with quite discrepant FRAX results. And I plugged in just the single risk factor of prior fracture into the Lebanese, the Abu Dhabi, and the Kuwait FRAX calibrations. And you can see that the risk of hip fracture varies by over double, as does the risk of major osteoporotic fracture, with Lebanon being far, far higher than Abu Dhabi or Kuwait. And it'll be interesting to see where Saudi Arabia comes in. So we ask, what is the risk of continuing or resuming therapy compared to the risk of discontinuing therapy? And that might be answered in part by looking at, again, a Medicare-Medicaid analysis recently done by Jeff Curtis, who looked at women enrolled in Medicare in the US, age 65 and older, who were adherent, greater than 80% adherent to alendronate, risedronate, or zoledronic acid for more than 3 years. And he found almost 82,000 eligible women who were observed for a mean of 4 years. 28% of them went on a drug holiday at one point. 73% of these women were on alendronate. That's the most commonly used bisphosphonate in the US. And hip fracture risk with drug holiday of greater than 2 years versus continuing on bisphosphonate, a 30% increase in the risk of hip fractures, or in documented hip fractures in those patients who went on drug holiday as compared to those who adhered. And he saw similar results with humerus fractures and clinical vertebral fractures, in each case, 20 to 30% increase in the risk of fracture with drug holiday as compared to continuing therapy. So this is the forest plot derived for alendronate, where you can see the 30% increase in the risk of hip fracture. Similar data with humerus and clinical vertebral fracture. No significant difference with distal forearm fractures. And he broke this down into risedronate and zoledronic acid with very similar results, independent of which bisphosphonate was considered. So our patient's concern is atypical femoral fracture, and I think we need to address that front on, and there are some interesting data which will help us with that. In the US, 50% decline in bisphosphonate use from 2008 to 2012, around the time AFFs first became publicized. And that decline in bisphosphonate use has been attributed mostly to the fear of atypical femoral fractures and perhaps osteonecrosis of the jaw. And yet osteoporosis remains underdiagnosed and undertreated in fracture patients who are at the highest risk of future fracture events. And indeed, in the US, over the decade from 2001 to 2011, there was a decline from 40% of patients who were given treatment after hip fracture to, in 2011, half that, 21%. And those at highest risk, the oldest age or males, certainly are not being widely treated. So how do we weigh the risk of the atypical femoral fracture as compared to the benefits of preventing typical hip fractures? Well, there was a very interesting article published late last year by Dennis Black looking at Rick Dell's data at Kaiser. Kaiser is a health maintenance organization in the US, and they had in their database 196,000 women over the age of 50 who received bisphosphonate between 2007 and 2017. And they had 277 AFF cases. Now, importantly, in this data set, every single one of the AFF cases was radiologically validated. This is not just probing an administrative database. It's a radiologist looking to see that these atypical femoral fractures have the distinct characteristics of AFFs, not just subtrochanteric in location. And they found that for 3 to 5 years of exposure to bisphosphonate, the hazard ratio was 8.9. And it rose to 43.5 with 8 years or more exposure to bisphosphonates. So those hazard ratios are pretty frightening, and they might be enough, if that's all you were looking at, to scare you off osteoporosis therapy. They also looked at ethnicity, and they found that Asians versus whites, the hazard ratio was 4.8, with Asians having a much greater risk of AFF. So these are the data as I broke them down. According to age, the age group 65 to 85 had much greater incidence, or rate, I should say, of atypical femoral fractures. These are expressed in rates per 10,000 person years. And if you looked at race or ethnic group, Asians being much more frequently affected than Caucasians, Hispanics, or certainly Blacks. If you look at according to the cumulative bisphosphonate exposure, then the incidence rate certainly increases dramatically as you go to longer durations of exposure. And once bisphosphonates were stopped in this database, you can see that as you progress from patients who are 3 months from discontinuing bisphosphonate, 3 to 15 months, 15 to 48 months, you can see dramatic fall-offs in the rate of atypical femoral fractures, such that after a year off bisphosphonate, the incidence of AFF drops down to a very low level. Now, if you look in an interesting analysis looking at typical hip fractures versus atypical femoral fractures, they plotted out here on the top bars in the dark blue typical hip fractures and in the light blue atypical femoral fractures. And you can see that the AFFs are such a small proportion of hip fractures that the bars hardly are visible. And as you get older, of course, typical hip fractures increase dramatically, with atypical femoral fractures not increasing in the very elderly. And so this is, I think, illuminating as to the benefit of preventing hip fractures with our therapies that might reduce hip fractures by 50% or more, as compared to the risks for AFF. And in the bottom panel, you can see according to race or ethnic groups, the AFF bar does show for Asian patients with an incidence of 6 per 10,000 patient years, as compared to typical hip fractures with an incidence of 20.4 cases per 10,000 patient years. So still a benefit in preventing hip fractures, but atypical femoral fractures being more common in that ethnicity. And they plotted out on a graph here for white women. You can see in the orange bar, the clinical fractures prevented as you go on to 5 years of bisphosphonate therapy, hip fractures prevented in the blue bars, and the atypical femoral fractures hardly rising off the baseline. And then they projected out what that would mean over a decade of therapy. And you can see by far the benefit is in preventing typical hip fractures and clinical fractures with a very few atypical femoral fractures occurring. In Asians, that purple bar of atypical femoral fractures is more significant and does increase. And you would say perhaps that there's a parallel increase to the rate of typical hip fractures as you go out longer on therapy. So the Asians being a much greater concern than Caucasians in terms of AFFs. So back to our patient after hip fracture, what should we do? Should we restart her alendronate therapy? Should we advance her therapy to intravenous zoledronic acid? What about denosumab? Or is this a good candidate for bone anabolic therapy with teriparatide or romosozumab? So zoledronic acid is the only agent which has a formal randomized controlled trial in patients after hip fracture. And these are data from Ken Lyle's recurrent fracture study, where he enrolled over 2,000 patients after hip fracture, and within 90 days either administered zoledronic acid infusion given annually or a placebo infusion, with everybody getting calcium and vitamin D. And it was an event-driven trial, but by the end of about 3 years, the reduction in any clinical fractures in patients on zoledronic acid as compared to placebo was about 35%, and that was highly significant. So anti-fracture efficacy in this post-hip fracture population has been documented with zoledronic acid infusion. And in the same study, looking at mortality, one can see that on zoledronic acid as compared to placebo, there was approximately a 30% reduction in mortality. Should we use bone anabolic therapy for this patient? Well, you could certainly say she is at very high fracture risk, having just had a hip fracture. We did her fracs, and that would also indicate that she's in a high risk category. And the concept of imminent fracture risk relates to the short-term risk of fracture in a patient who has had a recent fragility fracture. And we know that hip fractures do cause significant mortality, morbidity, and loss of independence. So this concept of imminent fracture risk looks at the risk of a second fracture after an index fracture. So these are data from Iceland looking at index fractures of hip, spine, forearm, and humerus. And we're making the point that in the first 2 years after an index fracture, the risk of a subsequent fracture is greatly elevated as compared to later on. Now, later on, the risk of subsequent fracture remains above baseline. The hazard ratio is greater than 1 as compared to people that haven't had a fracture. But you can see here for hip fracture, there is a 4.5-fold increase in the risk of subsequent fracture in patients with prior fracture, mostly manifest in the first year or two after that index fracture. And so that imminent fracture risk would again direct us to giving a potent and immediately effective therapy to our patient. So what about alendronate versus an anabolic, in this case romosozumab? And that was addressed in the ARCH study. And in the first 12 months, patients were randomly assigned to either alendronate or romosozumab. The postmenopausal women in the study had to have a vertebral fracture or a recent hip fracture, so our patient would likely qualify. And you can see that in new vertebral fractures, the primary endpoint after 12 months on romosozumab as compared to alendronate, there was a 37% reduction in the risk of fractures. And then all patients were transitioned to alendronate, and in those patients, 2 years on alendronate as compared to 1 year on romosozumab, and followed on 1 year on alendronate, a 48% reduction in the risk of new vertebral fracture. And I draw your attention as well, in those patients on alendronate over 2 years, almost 12% of them had a new vertebral fracture despite being on a good anti-resorptive regimen. Now, there was a very recent analysis published by Jacques Brown and colleagues looking at QCT of the lumbar spine to look more carefully at where the difference might occur between the trabecular and cortical compartments of bone at lumbar spine. So here you see QCT data in terms of increases in bone density In the green bar, patients increasing by about 14.7% on romosozumab as compared to 4.4% on alendronate. And then when all patients were transitioned to alendronate, you can see some further increases in bone density in those with the anabolic up front, maintaining superior effects to those just on alendronate from the beginning. And then they broke this down from integral, which is the combination of trabecular and cortical bone improvements. They broke it down into cortical volumetric bone density and trabecular volumetric bone density. And they showed that in both cases, the compartmental volumetric bone density was superior in those patients who got the anabolic up front, and that benefit persisted even as patients were all treated with alendronate after the first year. So back to our patient, in this case, monthly romosozumab was chosen, followed by denosumab, and that probably would be the most effective combination for such a patient, and arguing that she is at very high risk and high imminent risk. So a second case highlighting treatment failure, and this is a very common concern in terms of patient management. So here's our case, 69-year-old woman who began risedronate 9 years ago after hip bone density T-score is minus 3.9. So you might argue that with a T-score of minus 3.9, giving her an anti-resorptive therapy, especially of bisphosphonate, is unlikely to improve bone density to a level where you would consider fractures to be adequately prevented, say in the osteopenia range, -2, -1.5. And as expected, there was an increase in hip bone density and then stabilization at a T-score of -3.5. So she's now been 9 years on risedronate. Her most recent bone density showed that as compared to the prior, the T-score decreased and she went down by 4%. And so her T-score now -3.7. Does this constitute a treatment failure? And importantly, what would you consider could account for the decline in BMD? Well, Adolfo Diaz-Perez, with a working group from the International Osteoporosis Foundation, attempted a decade ago to define what treatment failure is. And their group made some arbitrary decisions just to cast up a straw man and to put in context what treatment failure could be. And they said not one, but 2 incident fragility fractures might define treatment failure. They said not just one, because we know that some fractures will occur in patients who are successfully treated with osteoporosis medications. And then they said that perhaps 1 incident fracture and an elevated bone turnover marker at baseline with no significant reduction during treatment, or a significant decrease in BMD, or both, could also constitute treatment failure. And they said also if there were both no significant decrease in bone turnover marker and a significant decrease in BMD, that could be treatment failure. But many jurisdictions, including ours, do not have access to bone turnover markers. And clearly we must make decisions, such as in our patient here, as to whether this patient has failed therapy and whether it would be reasonable to advance treatment in her case. So what could account for the decline in BMD that we see? Well, consider imprecision. So usually we express changes in bone density by a %. But be aware that if you had a decline of 0.1 grams per centimeter squared from a BMD of 1 gram per centimeter squared, the denominator, then that would represent about a 10% decline. If you had a decline of 0.1 grams per centimeter squared from a lower baseline, 0.5 grams per centimeter squared, as in our patient, then that would represent a 20% decline. And so one way around that is to, of course, express it as the grams per centimeter squared decline rather than as a percent. But commonly, if you look at the percent change, this is magnified in patients who have very low bone density, such as our patient. And so they might say at the densitometry site that this exceeds least significant change. But perhaps the effect is artifactually magnified by the low baseline BMD. There are other technical issues of imprecision, changes in BMD instruments, changes in technique, and those might also contribute to imprecision that could account for this decline in BMD. We should always scratch our heads and ask, could there be an emerging secondary cause of osteoporosis, hyperparathyroidism, vitamin D insufficiency, or malabsorption? We need to look into adequate calcium and vitamin D and nutrition with the knowledge that patients who are inappropriately or inadequately supplemented with calcium and vitamin D would get suboptimal effects from osteoporosis therapies. Weight loss has a major effect on densitometry, and some of that is artifactual. Mohammed Al-Mahoya has an abstract into the bone meeting this year, ASBMR, looking at modeling changes in fat and lean overlying the reference area and the vertebrae of a phantom, highlighting the effects of weight loss or changes in body composition as an artifact for DEXA. There might be surgical artifacts or lytic lesions. Of course, important was this patient taking treatment? Perhaps she was non-adherent to therapy. And we have generics for oral bisphosphonates, some of which may not have the same absorption as the brand. And so there may be issues of impaired absorption with some of the generics. Or it could be that this patient is a true bisphosphonate treatment failure and may have good reason to switch to a different treatment. So what are the options? Intravenous zoledronic acid, we've seen some data on that. Denosumab, or she could switch to an anabolic teriparatide or Rhomazosima, and having a very low baseline BMD, one might wish to consider anabolics for her. So what about switching between anti-resorbers? These are data putting together a number of studies. In the first set of bars, patients who had been long-term on bisphosphonate and were switched to denosumab or monthly risedronate, you can see BMD effects at lumbar spine being greater in those who got switched to denosumab as compared to continuing with bisphosphonate. In the second set of bars, these are patients who had been on long-term bisphosphonate and were then randomly assigned to a zoledronic acid infusion or a year on alendronate, and there was no significant difference in BMD change in the year after switching. And then the final set of bars are patients long-term on bisphosphonate, either randomly given weekly alendronate or denosumab, and you can see denosumab has superior spine bone density effects. So that's what we would expect if we switched between therapies for this patient. And you might argue, as did Mike McClung here in a recent publication, that with monotherapy, alendronate, zoledronic acid, denosumab, or teriparatide, you get different effects on spine bone density, with the greatest effects being with teriparatide, and different effects in hip bone density, plotted on the vertical axis, with the greatest effects with the bisphosphonates, alendronate, or zoledronic acid. But you get even better effects with combination denosumab and teriparatide, or the sequence that I showed you, Rhomazosima followed by alendronate, or even better, Rhomazosima followed by denosumab. So which one is better, Rhomazosima or teriparatide? We do not have a head-to-head study looking at fractures, but there was a smaller bone density and bone strength endpoint study done recently in patients who were postmenopausal women with more than 3 years exposure to bisphosphonate. The mean was almost 6 years, and with persistent hip bone density T-scores of less than -2.5. And this showed the bone density effects on the left-hand set of panels at total hip, femoral neck, and lumbar spine, superior in patients given romosozumab for a year in blue as compared to given teriparatide for a year in red. And we know that teriparatide effects on the hip bone density are pretty flat in the first year, perhaps to be made up in the second year. But here we saw superiority with romosozumab both at hip and spine, and you can see in the right-hand set of panels that integral cortical and trabecular bone was benefited to a greater degree with romosozumab as compared to teriparatide. We also looked at bone strength by finite element analysis and showed a superior effect of romosozumab over teriparatide in that study. So in case 2, with declining BMD on risedronate, cost and convenience were important to this patient, and the cost of anabolics certainly greater than many patients can sustain. And so this patient chose to switch from risedronate to denosumab. So those are a couple of cases, and I hope I've highlighted some of the important considerations that we have with some of the recent literature, and hopefully this helps to answer some of the questions that you may have with cases that you'll see in your clinic. Thank you for your attention.
Thank you, Dr. Kendler, for your presentation and the nice picture of Vancouver as well. And we would like to thank our participants for staying behind with us. And also we'd like to thank our speakers, Dr. Jumma and Dr. Yousef and David also for their clear and concise presentation about management of osteoporosis. There is some housekeeping stuff which from our organizers, the Gulf Association. And this evening you'll receive a feedback, which is important to them. And please give them their feedback. And also on that feedback, you'll receive information about the registration for their main conference, and also the last session for this course. As you know that this course is CME accredited by Dubai Health Authorities, and those who wish to claim the CME, please fill the registration form and send it back to them, and they will send you the CME hours as well. As you know, this course is organized and also supported by Amgen. They have given an educational grant for these 3 courses to help with the organization, with the speakers as well. So at the end, we will go ahead and review some of your question and give it to the speaker to clarify some of the points which was not clear. And since we have all of the experts, I'll just go one by one. We have around maybe 15 questions we have received. So the first question is about, so we'll start with Dr. Jumma. One of the attendees asking about menopausal patients. They were diagnosed with vitamin D deficiency, and they were placed on 50,000 international units. And his question, there is no availability of monitoring for after the therapeutic dose. So how do you monitor them, and do you give them further supplements, or? So he said there is a limitation in monitoring process. So
thank you so much. I assume that the patient would like to stick to the 50,000 and he would not change it. If we are not considering changing the dose to a different strength of vitamin D, then I would advise the patient to take the medication every 2 weeks. So on average, he takes 25,000 per week. As he take it. Other option to switch him to other doses, like 20,000 international units per week. That would be excellent option as well. If he would like to take it daily, then we would go for doses from 800 to 1,000 international units per day.
Okay, thank you, Dr. Jumma. Dr. Yousef, Dr. Salma is asking, how do we shall we treat secondary causes for osteoporosis before starting anti-resorptive medication, i.e. vitamin D deficiency, celiac disease? Do we treat those first before we start? And how long do we treat, and how when do we repeat the DEXA scan after initiation of treatment?
Okay, so treatment of secondary causes might resolve the issue with reduction in bone densitometry, for example, hyperparathyroidism. And I can see a question that I'm going to cover in my answer. So patient with hyperparathyroidism or vitamin D deficiency, severe chronic deficiency, can have a BMD score similar to osteoporosis. So first you have to treat it aggressively, retain good level of vitamin D for many months, and then you might repeat the BMD. Ideally, for patients with osteoporosis, the repeat of BMD should be minimum 1.5 years. For patients with vitamin D deficiency, I can see changes at even 10 months or 1 year if it's vitamin D deficiency. So if you treat them aggressively and improve their D status, they gain significant bone mineral density. The second one is post-parathyroidectomy for primary hyperpara. Again, the gain in BMD in studies has shown significant improvement in densitometry after removal of parathyroid adenoma. So that by itself can be enough to treat these patients if they have osteoporosis. The beta BMD, generally speaking, is 1.5 to 2 years. The best is 2 years, minimum is 1.5. The changes in BMD are so small and take a long time. So do not repeat the BMD, as I can see in some cases, in 6 months or 9 months or even 1 year. It's really that you're going to get major differences in readings if you do that at that interval.
Thank you, Dr. Yousef. David, one of them asking about pediatric patient with malabsorption history. Do they benefit from oral vitamin D or drops, or they need intramuscular vitamin D? Oral or drops or intramuscular for malabsorption syndromes?
Yeah, so obviously one would try first to correct as best one can the malabsorption if it's related to celiac, then to put them on appropriate diet, or if they have inflammatory bowel disease, to settle that. In which case, generally, the absorption can improve sufficient to be able to absorb vitamin D. In the case of short bowel syndrome, the drops can be an advantage over tablets, which may transit without the opportunity to dissolve. So drops might be quite appropriate. If one is unable to give enteral vitamin D, another approach would be to use ultraviolet lights, sun tanning, or I guess in the Gulf, you just need to go outside. And the skin is actually a very efficient machine for making vitamin D. So that's another way to bring vitamin D levels up. Indeed, here in Canada, where we don't have so much sunlight, we do have commercial vitamin D studios where you can go and get exposed to ultraviolet light in your skin and produce vitamin D. With regards to parenteral vitamin D, we do not have access to that in Canada, so I have no experience. And really, in general, the availability and the optimal absorption of the oral preparations or skin production meet our needs.
Thank you.
Abdullah,
Yes.
I have
Go ahead, Doctor.
experience with that. We do not advocate the use of parenteral therapy unless in very rare patients, those who are crippled with muscle weakness. And we faced some patients on wheelchairs with severe muscle weakness because of severe prolonged vitamin D deficiency. So these are the only type of patients that I give intramuscular vitamin D just to speed their healing. And once they are up on their feet, we change them to oral. Regular patients, mobilizing patients, do not use vitamin D. Even if their vitamin D is low, they can pick up nicely with the oral vitamin D, unless they have malabsorption, for example. Then these are the patients, short bowel syndrome, severe malabsorption, that you give them oral and they do not respond. Then you go for parenteral or intramuscular vitamin D.
Thank you, Yousef. Dr. Jumma, somebody is asking that, you know that we are going through a natural aging process, and can we, or to use hormone replacement therapy or growth hormone, and not to use an osteoporosis treatment?
First, growth hormone, I never came across that. Growth hormones as treatment for osteoporosis is unheard of. It's not being done. Yes, there is growth hormone used in the gyms now by the young people to build their muscles, and of course it has a positive impact in their bones, but it has a lot of negative consequences health-wise. So growth hormone is out of question. But the hormone replacement therapy still has some value. Probably Dr. David could add to that. But after the Women Health Initiative study in 2003, it has shown that probably there's increased risk of cardiovascular disease and stroke. And after that study being done, our use of hormone replacement therapy it's very hardly being done.
Yeah, no, that's correct. And you know, what we see is that if you're an early postmenopausal woman, then HRT, especially in the context of symptomatic menopause, is a very effective anti-resorber. But as you age, as you pointed out, if you get a decade after menopause, then estrogen has a much lesser anti-resorptive effect, and certainly lesser proven anti-fracture efficacy than our non-estrogen anti-resorbers. So the role for estrogen or HRT would be restricted to the younger woman with symptomatic menopause, where cardiovascular and breast cancer risks are lower, and there's a symptom benefit that they would achieve as well.
Thank you, David. Dr. Yousef, one of the attendees asking about the use of steroid therapy. Should we advise the patient, when to check their BMD or, doing the T-score? When do we start doing follow-up for those who use steroid?
So previously, we were not recommending doing a BMD routinely to patients on steroid, but that has changed with recent guidelines. So it's advocated that anyone who is going to continue on steroid more than 5 milligram, more than 3 months, to have a baseline BMD. It's now recommended. The follow-up is just like any other patients who is receiving prophylaxis for steroid therapy, 1.5 to 2 years, and the steroid induced osteoporosis is a huge topic. I can see the American College of Rheumatology guidelines quite complicated to me. And I wish that we find David is laughing. Probably he shares the same opinion. They made it so complex to people to digest and apply, actually. But generally speaking, above 5 milligram, more than 3 months, patients should be on prophylaxis, optimize their vitamin D and calcium. If they are on much larger doses for a long period of time, baseline BMD is now advocated, and a follow-up in 1.5 years is also advised.
Thank you, Yousef, for highlighting the point regarding repeating the DEXA scan, how often it is. But if we are worried about failure of treatment in a shorter period, say 9 months or 8 months, rather than depending on the DEXA scan, we could go for the markers of turnovers.
Absolutely, but they are not widely available, Jum'a. Yeah, so I'm not sure. In the kingdom, maybe 1 or 2 centers are doing them, but the majority, including ours, we don't routinely measure markers of pore resorption, and with budget restrictions now, even more important sort of laboratory workup are restricted from being sent outside for measurement.
Okay, thank you both. David, regarding, you have answered this, but on the chat box, somebody asked about the pathogenesis, how omeprazole causes osteoporosis, or it's a risk factor for osteoporosis. Can you just repeat for everyone what you have written for them about proton pump inhibitors and osteoporosis?
Yes, so there are observational studies looking at patients who are on PPI versus those who are not. And in some, but not all studies, there is an increase in fracture risk of about 20 or 30%. In other studies, there is no increase in fracture risk. And so the question is, are these studies which have biases, that is to say, do those patients on proton pump inhibitors have other risks for fracture which bring on the fracture rather than the proton pump inhibitor? And because we have no randomized trials or controlled trials where patients are assigned to PPI or not, we don't have the answer to that question. If it is a risk, it's a relatively small risk. And there are some theories as to why that might exist. Maybe one which is most widespread is that a proton pump inhibitor leads to achlorhydria, low acid in the stomach, and stomach acid is required to break calcium apart from other anions in food or calcium carbonate, for instance. And if you inhibit gastric acid, maybe the digestion of calcium and its subsequent absorption is impaired. Another theory is with some in vitro evidence as to its validity is that perhaps the proton pump inhibitor has a direct negative effect on the osteoblast. And so it's an osteoblast deficit. But these are just theories, and as I say, the epidemiologic or observational data are conflicting. It's not all studies would suggest there's a 20 or 30% increase in risk of fracture, but only some.
Thank you. And somebody is asking about Crohn's disease and vitamin D deficiency. How do we treat patients with Crohn's disease and vitamin D deficiency? Dr. Jumma?
It is the same as the one being asked before regarding malabsorption and vitamin D deficiency. So we need to first fix the underlying cause. So with treatment, you need to target the activity of the Crohn's disease, either with immunomodulating medication or steroids. Of course, you need to fix the vitamin D deficiency. So you would start the patient on oral vitamin D. It depends where the site is affected by the Crohn's disease, whether the site is, but in Crohn's disease, usually it has spots, certain areas. So the expectation that it may cause marked vitamin D deficiency, if a patient takes oral supplements, it's unlikely. So oral treatment could be of the major treatment here. If failed, yes, you could give drops or IM injections.
Okay. Dr. Yousef, Dr. Lejane is asking about, is there any anabolic therapies FDA approved for pediatric age group? Anabolic for pediatric, FDA approved?
Not up to my knowledge. Maybe David can comment on that. But pediatric osteoporosis is again a complicated issue, and the guidelines on them are not very clear. But generally speaking, you have to have a fracture beside plus minus reduction in Z-score. But you have to have a fracture to diagnose them as osteoporotic. And the treatment with anabolic, I'm not aware about any study in pediatric. Usually they are given anti-resorptive agents. David?
Yeah, exactly. So with teriparatide, there's a strict contraindication in patients with open epiphyses, and that because of the rat data where the epiphyses in a rat do not close throughout life, there is a risk of osteosarcoma. And so the concern is with open epiphyses, with a stimulator of the osteoblasts such as teriparatide, one might bring on that risk of osteosarcoma in children. So that's an absolute no. Rhomazosima is our other anabolic.
And there are absolutely no studies, and I doubt there ever will be studies with Rhomazosima in the pediatric group, since we don't know the effect of Wnt signaling inhibition in that population of patients. Wnt may be very important for development of the skeleton, and so there are some potential, although theoretical, downsides of using Rhomazosima again in the growing skeleton. We do not even have premenopausal data in the mature adult skeleton. In the case of Rhomazosima, the data are all confined to elderly skeletons, older postmenopausal women. And although not approved, we have trials with Rhomazosima in men with osteoporosis.
Thank you, David. David, you have already answered this, but again, to share it with for the audiences. One of the audience is asking, is it more dangerous to have osteoporosis or osteopenia?
Yeah, so our definition by densitometry of osteoporosis is a T-score compared with young normal of -2.5 or less. And for every standard deviation below peak, there's approximately a doubling of fracture risk. And so by the time you get to 3 standard deviations below peak, that's 2 times 2 times 2, or an 8-fold increase in the risk of fracture. And that with osteoporosis is certainly much greater than osteopenia. That's a standard deviation score of -1 to -2.5, which would have a 2 to 4-fold increase in the risk of fracture. So, of course, osteoporosis is the more predictive of future fragility fracture.
Thank you. Dr. Jumma, Dr. Muhammad is asking, he has a patient who has osteoporosis with secondary hyperparathyroidism. Patient refused surgery and initially, and he started him Indonesimab. But then the patient or she decided to change her mind and go for surgery. Should I be concerned of persistent hypocalcemia that may occur post-op? And what about the risk of rebound fracture risk, providing that trigger has been resolved? So risk of hypocalcemia, I guess, after treatment of denosumab, and rebound fracture risk.
I'm glad that she agreed for the parathyroid surgery. At least now the underlying cause for osteoporosis is over. As Dr. Yousef already touched on this, maybe hungry bone syndrome after the surgery there could be. So the remodeling of the bone will be accelerated. So we need just to worry about that. We give her sufficient amount of calcium with vitamin D supplementation at this stage. So we give her a good chance for her bone mineral density to recover. That's the main thing now. Shall we give her any other medication? Anti-absorptive at this moment, probably not. We'll just observe it, and within a year or 1 year and a half, probably her bone mineral density will recover. And we're going to reassess the situation after this period. Speaking about probably 1 year and a half, 2 years.
Okay. Thank you, Dr. Jumma. Regarding Dr. Yousef, regarding patient, Dr. Salma is asking, when do we decide to go for drug holiday? And how about switching between medication, anti-resorptive / anabolic? So drug holiday and switching medication.
The switching part has been demonstrated or shown by David. But generally speaking, we always recommend in high-risk patients to start with anabolic first and take advantage of this anabolic window and shift the patient after the end of the anabolic treatment to anti-resorptive and not the opposite. So this is the second part of your question. Now, drug holiday, as I mentioned, with bisphosphonates, with alendronate, the demonstration of efficacy is there for 5 years, and then after 5 years, assess your patient without fractures, with reasonable gain in BMD, you might think of a drug holiday and stop the patient. So if the risk is lowered after 5 years, then that patient need to have a drug holiday. and probably repeat the bone markers if you have them, bone densitometry after 1.5 years, and see if there is any sort of loss, significant loss, then that patient needs to go back on therapy. If you treat a patient with bisphosphonate for 5 years and you think that the fracture risk is still very high, then you might continue with the treatment beyond 5 years. Although, as I mentioned in the FLIX trial, the reduction in fracture was demonstrated only for clinical vertebral fractures. With denosumab, the studies has shown efficacy up to 10 years. And if you think that at one stage, for reason or another, you want to stop it, then put the patient on anti-resorptive after you stop denosumab because of increased rate of vertebral fractures after you stop therapy. To me, majority of my patients on denosumab are continuing. I did not reach a patient with 10 years since the medication is not available in our institution for 10 years. Probably soon we're going to approach that. And we don't find really, we did not see any sort of side effects or complication of therapy probably now 7 years since it's in our institution. Patients are tolerating very well the medication. And with alendronate as well, that's the bisphosphonate that we have. Some high-risk patients are continuing beyond 7 and 8 years without any sort of problems with therapy. So it's your clinical judgment. No fractures, reasonable reduction or improvement in densitometry, you might go for a drug holiday and repeat your BMD and see if they maintain their density, continue the drug holiday. If not, then think to restart your treatment. The management about this, the drug holiday needs to be individualized. So your clinical judgment plays a major role, plus what you know about the studies in this field.
Thank you. David, regarding special patient, for example, patient with Paget's disease, Dr. Fathia is asking, how about the risk of osteoporosis in Paget's disease? And also she's asking about the risk of osteoporosis in sickle cell disease. Sickle cell disease also, I see a lot of consult from hematology department coming to us regarding this population, and they are young, like, in the 30s. So how do you manage this group? So basically, Paget's and sickle cell disease.
Yeah, so Paget's disease is either monostotic or polyostotic. In either case, one might have Pagetic lesions which weaken bone and predispose to pathologic fractures. Those are different from osteoporotic fractures, but they are fractures nonetheless. We don't see a direct association of osteoporosis and Paget's disease, to my knowledge, except for the fact that Paget's and osteoporosis both increase in frequency with age, and so there may be some correlation there. The treatment, with the exception of anabolic, that is teriparatide, which would be contraindicated in Paget's disease because of both of them potentially increasing the risk of osteosarcoma, the treatments are similar. And I suppose if you have Paget's disease and you wish the most durable response, you would use intravenous zoledronic acid, which after a single infusion can give a long-term remission of maybe 70 or 80% out to 7 years after a single zoledronic acid infusion. So that would deal with both osteoporosis issues and Paget's disease issues. In terms of the hemoglobinopathies, sickle cell disease, I have little experience with that. We see a lot of thalassemia, which is also a hematologic hemoglobinopathy associated with osteoporosis. The reasons for that are unclear. It may have to do with alterations in the bone niche, that is where hematologic cells reside within bone and their effects directly on bone cells. Or in some cases, it may have to do with the overpopulation of hematologic precursors in the bone marrow with effects on the bone forming cells. In terms of treatment, the treatments would be similar to what we would use in patients without hematologic hemoglobinopathies.
Thank you, David. We have some. What? Anybody? Yes.
The doses, when it comes to budget disease, I had only one patient with budget disease, but the doses of the bisphosphonates you're giving are different than the standard patient with osteoporosis. I can't remember them, but they are different.
Yeah, so if you're using oral bisphosphonate, then the trials were with 40 milligram of alendronate for 6 months, or using risedronate, it was a 30 milligram dose daily for 2 months. So daily therapy with bisphosphonate orally, but that was inferior to zoledronic acid 5 milligram IV infusion on just one occasion. That is not annual, but one occasion. And then just following the alkaline phosphatase and perhaps the nuclear bone scans and seeing settling down of the Paget's disease in the majority of patients, 70 or 80% out at 7 years post single dose zoledronic acid. So standard of care, to my view, is a single infusion of 5 milligrams zoledronic acid.
Dr. Jumma, quick answer. Is there any role for vitamin B6 in osteoporosis? Somebody asked about vitamin B6 specifically.
No, I'm not aware of that. I know that excessive intake of vitamin B6 it causes neuropathy, is intoxication, and usually we see it in patients who take a neurobiome. Because the neurobiome has B1, B6, and B12. If somebody is taking too much of neurobiome as tablets, they tend to have B6 intoxications, and it is merely neuronal. I don't have if it has any effect in the bones. I have no idea, but I didn't read it anywhere.
Okay. Thanks, Dr. Jumma. We'll skip the FRAX question since it was last week sessions. We will go, Dr. Yousef, somebody asking, what's the best therapy for a patient who has their spine is unstable and they are going for surgery? And with osteoporosis, what's the best agent to use? I guess before surgery.
That will take us to the question of our colleagues in orthopedic surgeon using anabolics before surgery in patients with osteoporosis. I'm not sure if there is any sort of randomized trials. I'm sure there aren't. Maybe there are some studies which showed some improvement in morphology with anabolics before going to surgery, and the personal experience of our colleagues in surgery that patients with osteoporosis benefit from anabolic therapy, teriparatide at most, before going to surgery. I don't think there is any good evidence for such practice. And maybe David can have an input on that. No randomized trials saying that outcome of patients going for orthopedic surgery put on anabolics will be better than those who were not put on anabolics. So practically, you treat them like any other patients. If they are having had a recent fracture, put them on anabolic. Because of the Vero trial and the author is with us tonight, and the imminent risk data in various population saying that probably the fracture at most in the first 2 years. But apart from that, to improve the surgical outcome, I'm not convinced at all that there is good evidence for that.
Thank you, David. We have many questions remaining. So one thanking Professor David for the presentation. And he has a 56-year-old patient who had a T-score of minus 2.6 at the lumbar spine and normal at the hip. What we will label her as, will we label her as osteoporosis and start anti-resorptive agent? I guess lumbar is abnormal, but the hip is normal.
So that presents a little bit of a problem in terms of fracture risk assessment, because as you know, the FRAX system, if you're using that to estimate absolute fracture risk, involves only the femoral neck bone density and does not include, in this case, the lower bone density at lumbar spine. Bill Leslie has looked at a correction for those patients with discordant, that is lower spine bone density as compared to hip bone density. And it amounts to, if it's a per standard deviation difference between hip and spine, in this case, maybe one standard deviation, you could change the frax by about 20%. That is, increase it by 20%. So if you had a frax that was 15%, you would add 3% to that and it would become a frax of 18%. So it does make a difference, a small difference. Some of the guidelines would say if the bone density at spine meets the criteria of osteoporosis, as in this case, then you have bone density evidence of osteoporosis, go ahead and treat. The North American Menopause Society and the US guidelines would follow that direction. In Canada, we would say, well, probably you could afford to wait on such a patient. You could perhaps optimize calcium and vitamin D. Perhaps if it's a symptomatic woman after menopause, use estrogen to deal with her symptoms. And you could repeat a bone density after an interval and then make a decision based on the BMD trajectory. If things are declining, that would be a good opportunity to introduce treatment. So I think in that case, best to have a conversation with the patient. Some patients will be well motivated to initiate therapy early, to be very proactive with their bone health, perhaps in the context of a relative with fragility fractures. And other patients would be happier waiting for a year or two and seeing follow-up bone density and then making a decision at that point.
Yeah, can I comment, Abdullah, on that also?
Sure.
Yeah, so the other point is considering our situation in the Gulf region and considering that the DEXA scans in our region do not have our normative values. So we are comparing our readings to enhance. Actually, when you calculate the frax for our patient and select the country and put the T-score in the frax calculation, a notice will come to you that now you are referring your patient to enhanced data. And looking at the fracture rate in our region, probably would take the approach of our colleagues in Canada, as mentioned by David, treat based on frax. Age plays a major role here. So 2.6 in somebody who's 55 or 60, probably the frax will be not in the treatment range. And consider that the point that I mentioned in the beginning, that we are comparing our patients to North American or whatever software that you're putting in the DEXA scan machines in our region. So the best approach for our patient is to do the frax and treat based on the frax. I guess minus 2.6 will be low risk to have fractures in the coming 10 years, either major osteoporotic or hip. And probably observation is the best approach for such a patient. We recommend strongly, and this is what we put in our guidelines actually, the Saudi guidelines, that use frax to decide on therapy and do not treat based on the BMD alone.
Thank you, Dr. Yousef. Jumma, you can answer quickly these two questions. He's somebody asking about type 2 diabetes. How do you assess osteoporosis? I guess he's saying that they have high BMD. I'm not sure, type 2 diabetes. They have high BMD, type 2 diabetes. Usually it's low BMD.
We know from the 80s, 90s that type 1 is associated with osteoporosis, but by the early 2000s, we know that type 2 is also associated with osteoporosis as independent risk factor. And the evaluation in the patient with type 2 diabetes with osteoporosis, just like the normal population.
Regarding somebody is asking about use of large doses, he's writing 300,000 international unit for mild vitamin D deficiency. What's the danger of vitamin D intoxication or using large doses in mild vitamin D deficiency?
You mean injections? Yeah, to be injection, 300,000. Yeah, probably IM injections. First, there are 2 points here. First point is using intermittent injection of vitamin D for osteoporosis or prevention of osteoporosis. It is not recommended. There has been a study being published in patients receiving IM injection of vitamin D, and it showed that there is increased risk of fracture Probably because there is peak and troughs. There is the bone doesn't have hemostatic. That's one point. The other point is in our preparation here we have vitamin D available as lower dose given every 2 months, higher doses every 6 months, and even bigger doses like 6 months or more. But these it's difficult to follow up this patient unless I would give it only if there's absolute contraindication to taking oral tablets or other means of giving it.
Okay, thank
Dr. Yousef, want to say something?
No, actually, not really. I agree with what you said, Dr. Jumma.
So, Dr. Yousef, one of our participants asking, just you can answer quickly 2 questions. Regarding osteopenia, do we treat with pharmacological agents? And second is asking about patient with hyperparathyroidism going for surgery. Do we start anti-resorptive till surgery? I guess we answered that. Osteopenia, do we treat with pharmacological agents?
Not really, just calcium, optimize calcium and vitamin D, that's all.
Okay. And use of anti-resorptive prior to surgery in hyperpara?
Not really needed. Best therapy for hyperpara, osteoporosis related with hyperpara, is removal of parathyroid adenoma and has been shown by many studies. And I remember a long time ago, I came across several studies of Shoni Silverberg, David, I think you know her from US, which published many papers on the effect of parathyroidectomy in patients with primary hyperpara and the changes in BMD up to 12% in some of the publications she did with her colleagues. So best therapy for hyperpara is parathyroidectomy. No need to give anti-resorptive beforehand. It will not improve the surgical outcome or long-term outcome.
Okay, David, regarding bariatric surgery, when do we screen for osteoporosis? And somebody is asking an important question about use of osteoporosis medication in chronic renal failure with low PMD. So bariatric and chronic renal failure.
Okay, if I can add a comment about osteopenia. From Yousef's prior comments, we do rely on FRAX, and if you have enough clinical risk factors, a patient with osteopenia might have very high fracture risk. That's been amply demonstrated. So even with osteopenia, that might be an optimal time to implement FRAX and to use clinical risk factors to help to refine those patients who might best benefit from treatment. Bariatric patients are a challenge because we do have a lot of difficulties in getting accurate DXA measurements in those patients. Sometimes they're too heavy to fit on the DXA table. So we might not have a bone density, or we might have a bone density which is not particularly valid because of overlying fat. Furthermore, when they have their bariatric procedure and lose weight, there's an artifact of weight loss on bone density that makes it difficult to have a valid comparison. So sometimes we're dealing with what can only be looked on as a new baseline. So when do we do a bone density in a bariatric patient? The answer is when we can. Typically, we will look at a forearm bone density if the patient is too heavy to fit on the DXA table. If they do fit on the DXA table, and we do a bone density prior just to get some sense of where they are. And then we do follow generally at 6 and 12 months after their bariatric procedure when they will have lost a lot of weight. And we do that to encourage the diet and the conservative managements initially in these patients, to encourage their exercise, calcium, vitamin D, and then to have an opportunity to intervene at an appropriate time point, especially those who have bypass bariatric procedures rather than sleeve procedures. Second question is a real long one, but I'll answer it concisely, and that is, what about chronic renal insufficiency and treatments? The succinct answer is we have no therapies for patients with advanced CKD in terms of medications. That doesn't mean we can't use them. It just means there are no trials which have demonstrated evidence. And there probably won't be for a while, because this is a very problematic population in terms of adverse events. What do we do? Certainly optimize calcium phosphate control, manage issues to do with maintaining adequate calcium with active metabolite vitamin D, keeping the phosphate down with phosphate binders. If PTH goes too high, then parathyroidectomy or cinacalcet may be an opportunity to intervene. And as to the medications, no data on anabolics. The anti-resorbers, some people would use lesser doses of bisphosphonate, although there are no good data. Some people would introduce denosumab, although again, there are no data as to its efficacy in that population.
Okay, so I'll continue with you with the quick answers for a few questions remaining. How long do you continue calcium and vitamin D for osteoporosis prophylaxis?
Calcium and vitamin D for life. So we say calcium, you can achieve your 1200 milligram daily by 3 or 4 dairy servings. And if you can do that, then you don't need a calcium pill. That's just good nutritional advice. Vitamin D, we don't get through nutrition. And so we would recommend empirically 2000 IU daily or equivalent weekly or monthly to maintain vitamin D sufficiency. And again, there's no time limit with the greater need for vitamin D supplementation in older individuals, so greater reinforcement of that in the elderly.
Combine Fortis with denosumab in severe cases?
Only one convincing trial with combination, teriparatide and denosumab. That's the data study by Ben Leader. And that study showed that as compared to either teriparatide or denosumab individually, there was a synergy or a better effect on bone density by giving the combination, theoretically by opening up the anabolic window, suppressing the pro-resorptive effect of teriparatide, and allowing a more pure anabolic effect. We don't have any fracture data. There are some bone strength information from high-resolution peripheral CT that would be supportive, but we really lack any fracture data. And in the absence of that, that wouldn't be a mainstream recommendation. I would still advocate for monotherapy and the appropriate sequence of therapy as being optimal.
One of the participants asking, when do we start anti-resorptive treatment in a patient with on anastrozole therapy?
So we generally do a bone density and make a decision based on bone density. We do that because aromatase inhibitors are not included in the FRAX algorithm. You might fudge that by ticking the rheumatoid arthritis box and getting some approximation of the increased risk for fracture on aromatase inhibitor. But I see that as an area where we have an opportunity to be preventive. And so the answer, when do you start anti-resorber? As soon as you can after initiating the aromatase inhibitor. And that especially if you're going to be using bisphosphonates, since the data suggests later introduction. If you use zoledronic acid more than 6 months after starting aromatase inhibitor, you get a much less protective effect in terms of bone density.
One of the participants have a patient, a female 56. He did a back X-ray for her and showed osteopenia, plus or minus mild spondylitic changes. He started her on vitamin D, 5,000 once a week, plus calcitrate for 2 months. He's asking, do we need to do a DEXA scan or give another medication to prevent osteoporosis? No history factor.
What is calcitrate? Is that calcium?
Calcium.
Yes, calcium.
Calcium. Okay. I'm not
So
sure.
Only vitamin D and calcium.
Yes, so I'm not sure the direction that's going in, but certainly in addition to calcium and vitamin D, which is for everybody, if a patient has sufficient fracture risk, then we do have anti-resorbers for those patients who do not have a very high risk of fracture. And if the patient has an existing fracture, especially a recent fracture, then they might fall in a category of very, very high risk or imminent risk and be candidates for parenteral anti-resorber or anabolic therapy.
Okay.
I can add, Abdullah,
yes.
you can use FRAX, she can use FRAX, or he can use FRAX to decide if the patient needs BMD. So FRAX can be used for that purpose. So you put the risk factors and you see where she lies. If it's in medium or high risk treatment. If they are medium risk, then you do BMD for them.
Yes, Dr. Jumma.
Sometimes what I see in clinical practice is overuse of the DEXA machine. Lots of patients in their 20s, their 30s, and 40s, they've been sent for the DEXA machine and they come up with osteopenia or osteoporotic range and so on. Our use of the screening tool should be based on criteria. What are the risk factors for osteoporosis? Is there any evidence that the patient is likely to be having osteoporosis and depends their age group and so on? So that's need really to be taken into account before just doing DEXA.
Thank you.
There are some studies looking at applying a FRAX without BMD as a pre-qualifier for DEXA, according to your comments, Jumma. And that the SCOOP study in England showed that you could target patients, say, with a risk of hip fracture by FRAX without BMD for a definitive BMD and then a FRAX and ultimately treatment. And that pre-screen might be cost economic, and it might extend our ability to intervene in patients who are at risk and might not otherwise come to care.
Okay, so the last question, I think we touched on it. He's asking about Paget's disease with the chronic hypocalcemia and dialysis, how to manage Paget's on dialysis. I guess the same as chronic renal.
Yeah, except on dialysis, we have no definitive data in terms of what to do with bisphosphonates. You could perhaps argue that it doesn't really matter. You could still give a bisphosphonate in a patient on dialysis, and eventually the bisphosphonate would dialyze away in a similar fashion as to what the kidneys would handle it in somebody who was not anephric. But we really lack data. I would say if they have Paget's disease and they're not symptomatic or not imminent for fracture or complications of Paget's, I would probably leave their Paget's disease alone and deal with their dialysis and calcium, phosphate, parathyroid issues rather than going into bisphosphonates immediately.
Thank you very much. It's already 11 o'clock, almost midnight here in Oman, and thank for, I guess, in the Gulf countries as well. So I'd like to thank the 750 participants remaining with us. I'd like to thank Professor Jumma for, sorry, I did not manage to introduce you in the morning, but he's well known actually in our society and our country. So thank you, Jumma, for your lectures, and Dr. Yousef is also, thank you very much, and David, thank you for staying back with us. We'd like to thank Amgen for their support for these sessions, and also we'd like to thank the company for their support. Amber is actually running this show, and they are helping us with all the support.
Thank you so much.
Thank you very much, and good night to everybody, and thank you for patience. And one more thing, if you need any further information, there will be a recording available through the website of the Gulf Association, and also they have YouTube channels. So in the next 2 weeks, they will post, the presentation and the discussion for anybody to, who treat patients with osteoporosis to benefit from the presentation and the discussion. So thank you very much, and good night for everybody.